Professor Felletti. We have 15 minutes for each talk. If the speaker can finish 11. If the speaker can finish in 11 minutes, we can have a couple of questions or comment after each talk. Otherwise, we would have the discussion in the end. Thank you. Let us start.
Hydrocephalus with unknown. Good morning, and thank you for the invitation to this meeting. I have no disclosures. Patients with idiopathic triventricular obstructive hydrocephalus with unknown origin are often diagnosed with the general term aqueductal stenosis, and the pathological entities of late-onset idiopathic aqueductal stenosis, long-standing overt ventriculomegaly in adults, and late-onset aqueductal membranous occlusion have been introduced. The current definitions of LIAS and LOVA mainly refer to the clinical condition of the patients, pointing out the fact that hydrocephalus is chronic and symptoms are usually delayed in adulthood. These entities are valuable from a clinical point of view, but may be less useful for a neurosurgeon because they don't clarify the nature of aqueductal obstruction. Actually, patients diagnosed with LOVA can have a patent or an obstructed aqueduct and are treated with either VP shunt or ETV. Moreover, LIAS implies an obstruction of the cerebral aqueduct, but the nature and extent of the blockade varies from a segmental membrane to a long gliotic stenosis. The definition of LAMO has been clarified by Terada and colleagues as a triventricular hydrocephalus not diagnosed in childhood, where a membranous structure in the cerebral aqueduct impedes CSF flow. There is no other occlusive lesion, no recent subarachnoid hemorrhage, interventricular hemorrhage, or meningitis. However, the same study reports also cases published as LIAS, caused by membranous occlusion, confirming the confusion in the terminology. Moreover, although cerebral aqueduct membranous obstruction often manifests with symptoms in adulthood, it can be found also in the pediatric population. So besides the clinical condition of the patient, the nature of the obstruction is the most relevant feature from a technical neurosurgical perspective. And triventricular hydrocephalus due to membranous obstruction of the cerebral aqueduct should be clearly distinguished from other types of aqueductal stenosis. The first report of a membranous obstruction of the cerebral aqueduct dates back to 1908. This is quite impressive, as the diagnosis was initially based only on invasive radiological assessments such as ventriculography. Moreover, no therapy could be offered at that time. 80 patients with membranous obstruction of the cerebral aqueduct have been published in the literature. The early efforts to restore the patency of the cerebral aqueduct obstructed by a membrane were performed through a suboccipital approach and fenestration of membrane. After some failed attempts, Dandy was the first to successfully fenestrate the membrane in 1945. And for the following 50 years, open surgery through suboccipital approach and fenestration of the membrane was the only way to treat this condition. However, in the late 90s of the last century, endoscopy was introduced as a therapeutic option, which soon became the gold standard treatment, almost completely replacing open surgery to manage these patients. Although in some cases, a rigid endoscope has been coupled with a suboccipital approach, nowadays the use of a flexible scope through a precoronal bar hole is the most common technique. Such an approach actually offers the possibility to explore the entire length of the cerebral aqueduct. And our group already showed that the navigation of the cerebral aqueduct can be safely performed in these and other cases. Endoscopic ventriculostomy is certainly the most common surgical treatment in case of membranous occlusion of the cerebral aqueduct. The risk of ETV is low, but basilar artery injury remains a potentially life-threatening complication. And an unsuitable anatomical situation at the floor of the third ventricle increases the hazards and decreases the success rate of ETV. Aqueductoplasty for aqueductal stenosis carries the risk of periaqueductal gray matter injury, and it cannot be performed in all cases. However, when a membrane is occluding the cerebral aqueduct, it has been shown to be a relatively safe procedure. Therefore, a distinction between aqueductal stenosis due to gliosis and membranous obstruction of the cerebral aqueduct is relevant in order to offer the proper treatment, minimizing the risks for the patient. Aqueductoplasty has some advantages compared to ETV. It restores the physiological CSF pathway. It carries no risk of injury to the basilar artery, and hypothalamic damage is not possible. Finally, it is also possible to couple ETV and aqueductoplasty with the aim of creating two distinct pathways for CSF, although it has to be determined whether this would be more effective in reducing the risk of recurrences, or it would be an increase of the odds for a restenosis as CSF pressure is divided between ETV and cerebral aqueduct. This is our series of 9 patients with membranous occlusion of the cerebral aqueduct. In most of the cases, we performed an aqueductoplasty, and in some patients, we did an ETV, obtaining an improvement of symptoms in all cases without any complications, besides transient diplopia in a patient that resolved in 17 days. One patient who was also affected by atresia of Monro foramina had a recurrence of symptoms 6 years later and was treated with BP shunt at another institution. Another patient, initially treated with aqueductoplasty, required ETV 2 years later with complete recovery. Interesting enough, this young patient was admitted to our hospital with acute symptoms and comatose status, which is very uncommon in case of membranous occlusion of the cerebral aqueduct, being symptoms usually progressive. After confirming the membrane, we fenestrated it using monopolar and also, of course, Fogarty balloon, and we restored the CSF pathway, and the patient completely recovered. The postoperative MRI shows the decrease of the third ventricle volume and also the decrease of the cerebral aqueduct diameter. Also, in this patient, we decided to perform only aqueductoplasty. It is very important to select the proper area where to fenestrate the membrane, avoiding the more dorsal part of the aqueduct and pointing to its ventral side instead. Directly the scope to the dorsal side would increase the risks to damage the superior medullary velum, where the fibers of the trochlear nerve cross the midline, and the patient could have postoperative diplopia. So in this video, you can see the fenestration of the membrane, and again, with the Fogarty balloon, we enlarged this fenestration with exploration of the fourth ventricle. After successfully fenestrating the membrane, the symptoms significantly improved, and MRI showed good CSF flow through the aqueduct. However, 2 years later, the patient reported worsening symptoms again, and I decided to repeat endoscopy. I confirmed a restenosis of the cerebral aqueduct with a thicker membrane compared to the first operation. Therefore, I did ETV, and the patient improved and is still doing very well. What they noticed in this case is that the mesencephalus had this altered signal at the level of the membrane, and I hypothesized that some kind of local inflammation determined the restenosis. It will be interesting in the future to try to identify any possible factors related to an increased risk of restenosis in these cases. In conclusion, it is crucial to make a careful and precise diagnosis in patients with obstructive triventricular hydrocephalus to recognize the subset of patients with a membranous occlusion. Nowadays, specific MRI sequences as Fiesta or 3D Drive are very accurate for thin membranes, although direct endoscopic exploration provides the definitive diagnosis. Both aqueductoplasty and ETV are effective treatments with very high success and low complication rates. Thank you very much.
Thank you. Thank you very much, Alberto, for finishing on time and such a good talk about the aqueductoplasty. We have time for a brief question or comment if anybody wants to make. Yes, please. Is he connected to us or is not there? He's not with us. There she is. Hello, Alberto. Can you hear us? I think there's no sound there.
Dr. Alberto, can you please speak louder?
Alberto, can you hear us? No, I don't think there is two-way communication. If no, then we move on. We'll go to the next speaker. Okay, so I think we move on to the next talk, and this is going to be by Alberto Sufyanov. Albert Sufyanov is a pediatric neurosurgeon and a neuroendoscopic surgeon from Russia, and he's going to talk about the exoendoscopic surgery of brainstem lesions.
I am Professor Albert Sufyanov. I am from Tyumen, and I am chief of Federal Center of Neurosurgery, located in city of Tyumen. Okay, the neurosurgery is very interesting field, and the neurosurgery just introduced a lot of many technological things for develop good and excellent results. So why in this slide possible to see the evolution of the for example, intraoperative imaging in neurosurgery, because intraoperative imaging in neurosurgery is one of the main important facts, things, events, just for good result after operation. Cystoscope and endoscope combination, also very important in this kind of surgery. 3D in endoscopy, it's really adventurous, and now it's bimanual binocular neuroendoscopy. It's possible. And we use stereo vision technology. This is new possibility. So next, I want to show our experience by case report about the cystoscope for the posterior fossa surgery. You see the lesion near the brainstem, so it's really not easy case for approach and for the dissection. Most important in this kind of surgery is the localization of the exoscope. The operation team is very important just to manage before the operation. We see the example for this kind of surgery. The exoscope, the holder, pneumo arm from Mitaka, and some special monitors. 4K monitor from exoscope is a very high quality of the image. It's very important. This is the conflict side. Conflict they are placed. Again, open more brainstem, dissect more, and now you see very beautiful picture about the brainstem, an entrance zone of the 7 inside of the brainstem. And you see the very easy and comfortable the place of the conflict. By moving, easy moving of the heat of the exoscope, because exoscope is very small heat, not like microscope. So it's possible to create very easy VU, angle of VU of the exoscope, very easy. So why it's enough even small approach to the brainstem. And we put the protector, and you see how it's nice quality of the picture. We combine now possibility of the exoscope and endoscope just for minimize the approach, the minimize the trauma for the brain, the minimize the traction. Now fibrin glue just to fix the protector. This is final view after operation. This is after operation. You see the happy patient. Also, it's possible to use this kind of surgery by exoscope, the trigeminal neuralgia also. I don't show the whole operation, but only to show some fragment of the operation of the control during the operation. Also, it's possible to combine not only 3D endoscope by combine endoscope with the ICG control. And you see, with the endoscopic ICG control about the vessels around the trigeminal nerve. Nice view. It's really small approach, you see. Really keyhole approach. But possibility of the endoscope and exoscope and combination give us good possibility with a good result. You see how large magnification and how in detail it's possible to see the vessels, the brainstem. Again and again, the comfortable position of the surgeon, not like in microscope, and assistant also. It's really big tumor. You see this is the top, is the bottom, just before the all neck, filled by the tumor. You see the craniovertebral junction completely. You see, very important to minimize the trauma, especially in the child's surgery. And now we see the tumor. During the operation, it's possible to change some possibility of the exoscope, you see, and to visualize the better the tumors, the vessels, the dura, you see like this. Also very useful option. Clara, chroma, spectra, so a lot of possibility. Now they open the dura. Open more, just near the craniovertebral junction. And you see how it's easy to move the VU. Magnification, very easy. We open brainstem, we open the tumor, we open the cerebellum, release the CSF. again and again, high quality of the image, high quality of the picture. It's very important in tumor surgery because we must differentiate very easy, very precisely the difference between tumors, brainstem, cerebellum, and so on. You know. And then we start to close. After closing. Even brainstem surgery is possible by exoscope. You see the case. Cavernoma in the place of the pointing. This is anatomical specimen just for understanding anatomy. You see every tight navigated point. We know where I now during the surgery, because inside of the brainstem it's a little bit difficult to orientate. After removing, not small. Now we see inside, total removing, not total removing. Just to clean at first and fill by the water, and then we introduce 3D endoscope. 3D endoscope, just to see. This is exoscopic control, this is endoscope, this is aspiration, this is endoscope inside. And this is a picture from a 3D endoscope. So no remnants. After surgery, total removing. So now I try to show some advantage of the 3D endoscope in neurosurgery. First one, from our opinion, is ergonomic comfort for the surgeon, especially important for the difficult long-time surgery. Because sometimes with microscope, it's not possible. Ability to see the entire surgical file and rapidly switch from the micro to micro vision, micro to micro vision. Ability to scrub nurse to participate more actively in procedure. Most important is the LED-based illumination generates less heat than the operation microscope with the halogen lighting. Especially important for the brainstem surgery. We know about it. Again, it's very portative. It's possible to take the exoscope and go in any place in the world and make high quality of the surgery. Also, one of the most additional, I think, especially for the developing country, and also cost. Also very no compare with the microscope. Also very important for the developing country. But some limitations also we have. One of the most difficult for me was no real freehand manipulation. So we need stay one assistant just only for moving. Manual reposition of the exoscope during the procedure is difficult and takes longer than with the microscope. But future development, I think it's possible in near future. And the introduction of the robotic stents give our possibility, and this limitation disappear, I hope. 3D endoscopic assistant and combination also very important, especially for deep lesion location. So hemostasis control of remnants, reducing the risk of postoperative complication, the limitation of the approach, smallest approach is possible. So minimalization of the surgical intervention is possible. So also this combination is very useful in my opinion. Conclusion. So considering of the advantage of the 3D exoscope and our experience with it, this technology is safe, efficient, convenient, and can be alternative to the operation microscope. Combination of the exoscope with the 3D endoscopic assistant minimize the risk of the postoperative complication. But learning curve of the surgeon is very important. And we have the cadaver lab where we have the experience with the device. And I want to say a lot of thanks to our leader, Professor Luis Borba, for his kindly relation for this device and his idea about the organized first workshop in Tumen in October 2021, just for exoscope neurosurgical anatomy dissection and research, and live surgery by introduce this new device scope in current neurosurgery. And you see the step of our this very interesting workshop by exoscope. You see the exoscope, cadaver head, how we study the anatomy. Thank you very much for your attention. I am Professor Albert Sufyanov. I am from Tumen, and I am chief of Federal Center of Neurosurgery, located in.
Well, thank you. Thank you very much, Professor Sofyana, for this brilliant presentation. I don't know whether we can communicate with him.
So Dr. Cordoba is joining us. He asked us, like, no, he's going to join us in a minute, sir. He just messaged us.
Oh, okay.
Dr.
Fine,
Cordoba.
fine. So we can ask later. Yeah. Anybody has a quick question or comment about this technique? Yeah, Professor Yadav, please. Give him a mic.
I think very nicely covered exoscopic surgery. But the main limitation of exoscope, which I think he forgot to mention, is visualization at the corner. And therefore, when he was operating with the exoscope, he took help of endoscope to see at the corner whether that lesion in the brainstem was removed totally or not. So this is the main limitation of the exoscope, which at present it cannot be overcome.
How often do you need endoscope in exoscopic vision? How helpful it is?
I think, see, I don't use exoscope. Dr. Parihar, he does all these surgery. It's quite good tool, but to me, it looks that the main problem of exoscope is inability to visualize. The visualization in the microscope and exoscope is same. Both cannot visualize at the corner, which is the main advantage of endoscope.
No, for the past 15 days, we have been using Surgiscope. That's an exoscope of Asclab company. And we have done transpinodal surgeries with the exoscope. And because the arm is robotic guided, we can angulate and see the angle. So it means it's better than microscope. It's something in between microscope and endoscope. So, but it is definitely better than microscope. And the visualization even at the depth was as good as an endoscope when we used that exoscope. So it's means our experience has been quite good with that, with exoscope.
We have Professor Nashiyama with us. Kenichi, your comment, please.
Thank you. It's a good paper. I think the strong point of the exoscope is a wide field of view and the deep depth of field. So maybe for the posterior fossa tumor surgery is the best indication. But we have two problems. Number one is the axis of the surgeon's eye and the hand is not parallel. So it is sometimes it's difficult to operate during operation. Manipulate during operation. And the second one is when you introduce the endoscope at that time. Because, sometimes in the posterior fossa tumor case or the posterior fossa surgery, the keyhole is not so big. So we need an endoscope, but it's at the surgeon's skill. And also that maybe the color is different. And we have now in the three companies of the exoscope, we can use that's Olympus and the Zeiss and the Vibram Nesgraph. The three is all different. So we have to know about the mechanical design and how to use it. That is my point.
Thank you. Dr. Pariyar.
Thank you, sir. It's rightly said by Professor Yadav that one thing should be made very clear that it is not a replacement of endoscope. Exoscope will never replace the endoscope. Still, especially we're looking at the corner. So it is basically a property, has got a property between the microscope and endoscope. So people, those who want to learn the endoscopy, they have an advantage of doing surgery while looking at the monitor. So hand-eye coordination is one of the advantage which you can, one of the skill which you can acquire by using the exoscope. And the looking to the developmental technology and coming to the various type of exoscope, it has got a very potential to that it may replace the microscope in the future. But definitely endoscope got is definitely a point. If you feel that like microvascular decompression, that you are not been seeing the conflicts anterior to the nerve, then definitely I would recommend to use the endoscope to make doubly sure. Thank you.
Well, thank you very much for your comment, and we move on to the next talk.
Excuse me.
Yes, please.
Yes, I have a very short comment. First of all, I'm sorry, I had a connection problem 10 minutes ago. So if there are questions for my talk, I'm ready to take them. I had the chance to use the exoscope just a few times. I think the most advantage, the major advantage of exoscope is in posterior fossa in the sitting position, because it uncouples the direction of your hands and of your eyes. So probably I felt it's more comfortable for your neck. But besides that, I think it's actually alternative to the microscope right now. This is just a short comment.
Okay, thank you. Thank you very much for your comment. And I think let's go on to the next one. So I would like to invite Professor Chinali from Naples to deliver his talk. And he's going to talk on the endoscopic aqueductoplasty in isolated fourth ventricle. Professor Chinali, please.
Thank you, Suresh. Can you hear me?
Yes, we can.
Okay, thank you very much. And sorry again for not being there with you. And sorry if there is some noise from the environment since I am in the operating room. Glad to talk about the aqueductoplasty for the isolated fourth ventricle, the surgical technique, the complication, 15-year follow-up, my disclosures. And as you know, the isolated fourth ventricle is an isolation between the fourth ventricle and the CSF pathways due to the obstruction of the aqueduct and on the fourth ventricle addressed towards the basal subarachnoid spaces. The etiology in the infancy is following VP shunt for post-hemorrhagic or post-meningitic hydrocephalus, and at a later age, mainly in our experience following complex posterior fossa surgery in the pediatric population. Diagnosis is often incidental on follow-up MRIs, or sometimes due to clinical symptoms for brainstem compression. treatment options traditionally have been the placement of a shunt in the fourth ventricle, or aqueduct cannulation with the microsurgical technique, microsurgical fenestration of the fourth ventricle outlets, all options that are effective, although quite significant complications are associated with the placement of a shunt in the fourth ventricle. So certainly this is the solution that should try to be avoided. But otherwise, the endoscopic procedure are certainly the ones who have give a revolution in the treatment of isolated fourth ventricle. Our indications to the aqueductoplasty, when it is feasible, is when we are talking about the membranous obstruction of the aqueduct, or with a short segment aqueductal stenosis, less than 5 millimeters in the length. This is a typical case of membranous obstruction of the distal third of the aqueduct, ideal condition with very large supratentorial ventricle, very large isolated fourth ventricle, and just a very, very small membrane to perforate. This is certainly the better condition, but very frequently the situation is very different from this, and very frequently the patient has associated slit ventricle above, and so very frequently the management of this condition is a little bit more complex. Our techniques that are not alternative are associated ETV versus aqueductoplasty, because normally in conditions like this, the ETV is not able to resolve the hydrocephalus alone, and very frequently we have to associate ETV and aqueductoplasty. Our 20-year institutional experience in the Santobono Children's Hospital in Naples has been published recently, 1 year ago. From 1999 to 2019, we had 33 patients and 50 procedures. So this is not a very frequent procedure, just a couple of times per year over almost 20 years, but quite frequently, several times in the same patient, with a median age of 7 months, so very, very small children population, with 22 patients preterm. More than 66% of the patients were preterm, indication of the fact that the isolated fourth ventricle is typically a problem of the premature population, with a mean follow-up of 63 months. The etiology, as you can see, mostly 37% were post-hemorrhagic, 33% were post-hemorrhagic plus post-infective, some kind of for example, a premature baby that witnessed some infection due to Ommaya reservoir or some other surgical procedure performed, and then 15% were uniquely post-infective hydrocephalus, and very rarely PCF tumor or PCF tumor for hemorrhage or congenital isolated fourth ventricle. Surgical technique is very special. As you know, if we compare the traditional location of the bar hole of an ETV, the angulation of the aqueductal localization is requires a much more anterior bar hole, that is basically in the middle of the forehead, anterior to the hairline, in order to be in the perfect inclination to see the inlet of the aqueduct and to perform atraumatic and safe perforation of the membranous aqueduct. So the bar hole location for third ventriculostomy is just anterior to the coronal suture. The bar hole for the aqueductal stent is much more anterior, but we try to customize, and we try to always find the correct location by navigation. Our technique is very simple. We put the target at the level of the aqueduct, then we put the entry point in the middle of the foramen Monroe, and then we prolong our trajectory on the forehead, and we found precisely what is the precise location of the bar hole in order to be in perfect inclination to find the aqueduct and to prolong our trajectory of the aqueductal stent to place inside the fourth ventricle, and in order to have a perfect placement on the endoscopic aqueductal stent. This is a small video showing that sometimes the anatomy can be very complex to identify. This is the choral plexus, and sometimes we can have a foramen Monroe that is very complex and to identify. Sometimes the anatomy can be tricky, so we have to use navigation in all cases. In this case, we are in the third ventricle already. We see the infundibular recess anteriorly. We can identify it, and then posteriorly with the navigation, we can identify precisely the inlet of the aqueduct, the membrane that is occluding the inlet of the aqueduct, and we can perforate with the Fogarty balloon. And you can see how easy it is when we are in a perfect inclination of the endoscope. We see immediately the inlet of the aqueduct. We don't have to adapt our trajectory to the patient, so we are perfectly oriented. We see immediately with the navigation the inlet of the aqueduct, and after perforation of the membrane of the inlet of the aqueduct, we go back inside the lateral ventricle. We insert our stent and we visualize our stent. This is our stent that has been just introduced, and we can see our stent entering inside the tip of the aqueduct and inserted inside the foreventricle in order to have a proper drainage. And we can see here the additional barcodes that are created right above the tip of the ventricle in order to have a correct drainage. When we have, this is our flow chart, when we have large lateral ventricle, a functioning supratentorial shunt, then in this case we do a precoronal approach plus stent. And if we have a supratentorial shunt malfunction, we do a precoronal approach and we modify our ventricular catheter and our VP shunt system, trying to modify and to simplify using a single catheter stenting both the aqueduct and the supratentorial system. If instead we have a narrow lateral ventricle, then either we upgrade the valve or externalize the shunt if the patient can tolerate in order to do a ventricular aqueductoplasty from above. Either we do a suboccipital approach. Suboccipital approach, like in this case, we have a functioning supratentorial shunt, we have a symptomatic isolated foreventricle in the posterior fossa, and we can do a suboccipital approach always with the navigation. We can see the inlet of the aqueduct from below. We can perforate the membrane that is inside the aqueduct. You can see very nicely that this is the opening of the membrane that is being just performed, and then we include our stent inside the aqueduct, and we can stent from below with a suboccipital approach that is very, very effective method. So this is very effective, and this is the post-operative MRI, and you see with the correct calculation of the stent, you end up in a very precise way in the either in the third or in the fourth ventricle. So temporary aqueductoplasty can be used as a fourth ventricle subgaleal shunt in the case of isolated fault in a very low weight premise. In this case, for example, unfortunately the video does not start, but this is a subgaleal shunt draining at the same time with the same catheter the foreventricle and the supratentorial system and ending up in a subgaleal pocket. So this is very frequently used in the premature population. In 28 out of 33 patients received pre-surgery before aqueductoplasty. 18 out of 28 patients received extrathecal diversion procedure. 5 out of 28 patients received a combination of extrathecal diversion and endoscopic procedure. And 4 out of 28 received PCF tumor resection further CCA diversion procedure. So you can see that these patients are quite complex, and very frequently they must be associated to previous surgery. And then at the time of first aqueductoplasty, 2 out of 33 received aqueductoplasty without stenting, and the different endoscopic maneuvers were performed. In 15 cases, TTV was associated, and 31 out of 33 patients received a stent that was connected to a pre-existing shunt in 3 cases, new VP shunt in 9, subgaleal in 2, Omayo reservoir in 6, and Y connected in 1 case. So very frequently associated to other procedure. So 10 out of 33 were never reoperated since. Otherwise, more than 2/3 of the patients underwent further surgery after the first aqueductoplasty. And this is the survival curve of our aqueductoplasty with a very long-term follow-up. As you can see, all procedures were successfully performed with immediate improvement of the symptoms, no mortality related to the procedure, and no intraoperative complication with a very, very long-term follow-up after the first 3-4 years, you see that the aqueductoplasty is to be considered a very stable and well-functioning system. The only complication, significant complication, was this one. Due to the hyperdrainage of the fourth ventricle, the patient had a double sixth and seventh cranial nerve bilateral palsy, and that was resistant to every sort of adaptation of the entry point. This is an illustrative case, a preterm born at 28 weeks with an AVH grade 3 ventricular subgaleal shunt that was done, converted into a ventriculoperitoneal shunt. The shunt is functioning very well, but we have an isolated fourth ventricle that continues to grow, that becomes symptomatic with vomiting and drowsiness. We perform an endoscopic aqueductoplasty from above with the stent connected to the Ommaya reservoir. As you can see here, the stent is properly placed through the aqueduct, but then progressively the stent is pulled out, and we have small third ventricle. So we decided just to remove the Ommaya without further increase of the fourth ventricle. We revised the supratentorial shunt without new stent, but then we have a new progressive enlargement of the isolated fourth ventricle. So if we don't place a stent inside the fourth ventricle, isolated fourth ventricle will tend to recur. So we need to place a stent, and then we, because of a peritonitis, we put an EVD. We did a progressive enlargement of the ventricular system, and then we were able to perform an endoscopic aqueductoplasty, and we replaced finally a stent inside the fourth ventricle. So don't leave an isolated fourth ventricle without a stent. Always leave a stent behind you, connect if possible to a functioning ventriculoperitoneal shunt. So in conclusion, the endoscopic aqueductoplasty is a reliable procedure in long-term management of isolated fourth ventricle in a pediatric age. Even as a transient procedure to manage acutely patient not yet eligible for permanent extrathecal shunts, the placement of a stent in the aqueduct is more effective in preventing the repeated occlusion of the aqueduct, and in case of revision, endoscopic replacement is a valuable and feasible option. Thank you very much for your attention.
Thank you. Thank you very much, Professor Chinali, for this brilliant talk. And I think the talk is open for discussion if anybody has any question.
Thank you, Pepe. Can you hear me?
Yes, yes.
Okay.
Good morning.
Yeah, good morning. Nice. Always I enjoyed your wonderful paper. And of course, I think, as you know, the aqueductoplasty with stent plus shunt is one of the good indication for the isolated fourth ventricle. But since I don't like to make a new barhole for a child or for the young boys and girls, so I use the previous barhole and to go to the endoscope to the lateral ventricle and to go to the medial side and into the quadrigeminal system and to go to the fourth ventricle via the superior medullary vein. So how do you think about this approach to go to the quadrigeminal system? I sometimes use nowadays.
Through the quadrigeminal cistern through a parietal barhole, I did it a couple of times a long time ago in a very huge isolated fourth ventricle that was herniating through the Pacchioni foramen in the supratentorial system. And in this case, this is a fantastic option, of course. But with this is from the old time. Now that we are monitoring our premature population very closely in the earliest years, we detect our isolated fourth ventricle much earlier than a long time ago. So we are facing the problem of a huge fourth ventricle, but not as huge to be operated through the quadrigeminal system. Mm-hmm. So we still prefer to make the simplest procedure as possible and to identify the best possible trajectory with the navigator and to do a brand new anterior barhole to perform the procedure. Because the only interest of my paper is because this is a very well-known procedure. Everybody does it very well. The only interest is the very long term that we had follow-up. And we have seen that after the first 4 or 5 years, the aqueductoplasty works very well. That there is a flat line and the ventriculoperitoneal shunt don't fail anymore. So I think that having a frontal approach with one single catheter with a functioning ventriculoperitoneal shunt is a guarantee for the very long term of these patients.
Okay. Yeah. I understand and I agree with you, of course. And the aqueductoplasty is working a long time. But and you know, the isolated forced ventricle is a big problem for the pediatric neurosurgeon. So we should have some options to treat it.
Yeah, absolutely. It's been a dramatic revolution in the treatment of this disease. Very important. And if someone of the people who is listening to us is not performing this procedure, I strongly suggest to try it, because it's a life-changing procedure for the patient. Really life-changing.
Anyway, thank you very much for a wonderful lecture.
Thank you, Kanish.
Thanks, Pepe. And can you just tell us what is the rate of stent migration or occlusion or something like that? And if it happens, how do you manage the case?
Yes, you have seen, thank you for the question, Suresh. You have seen that almost 60% of our patients require further procedure. Of this 60%, at least the half are due to the fact that with the growth of the head, the aqueductal stent progressively goes up because the head is growing, and the baby are very small because they are premature when the stent is inserted. And so at the end of the first year of age, the aqueductal stent frequently comes out and goes up into the third ventricle. And in this case, we have to replace the stent from the endoscopically with an additional procedure through the frontal barrel. So this is the main problem, and I have no solution for this. When we implant the stent very early in life, then almost invariably it needs to be revised by the end of between 12 and 18 months of age, because with the growth of the head, the stent comes out progressively.
Thank you, Pepe. Anything you would like to say? No, fine. Right. Thank you very much for this brilliant presentation and nice discussion after that.
Thank you.
We'll now move on to the next speaker. I would just like to make an announcement that if anybody wants a cup of tea or coffee, it has been served there, so you can help yourself. Our next speaker is Cavallo, Professor Cavallo. He is Luigi Cavallo. He is from University of Naples, skull-base endoscopic surgeon. Can we start his talk, please?
Yes.
Hello, everybody, in the meanwhile.
Is he live?
Hello, can you hear me?
Yes, we can hear you, please.
Hello, everybody. And nice to see you again, all of you.
All right, thank you, please.
And thanks for the invitation.
Put his talk on, please.
Hello, everybody, and thanks again for the invitation. And I'm really sorry for not being with you in Hyderabad. My topic today is to speak about the endonasal management of midline skull base meningioma. And these are the kind of tumor of meningiomas that we can treat through the endonasal route. And as you can see, through the nose, we can realize quite large skull base opening on the midline skull base. So if we have to realize such large opening, we need also a good reconstruction technique to seal properly such big hole. And this is the technique we are actually using, which allowed us to reduce significantly the rate of post-op CSF leak. From our series of more than 2,400 patients, we collected over the years more than 90 meningiomas, and as you can see, the vast majority are represented by tuberculous cell meningioma. These are the basic concepts when we want to remove a meningioma through the nose. We need a bilateral corridor. We have to perform wide spaniotomy and also to resect at least 1 meter turbinate. We need some dedicated and adjunctive tool, especially low-profile instruments are absolutely necessary to perform such kind of surgery. And I would like to start with one particular kind of meningioma, the one growing inside the cavernous sinus. As you know, today the vast majority of this tumor can be treated with gamma knife with excellent result, but still there is a role for surgery and also for sphenoidal surgery with the aim to decompress the cavernous sinus, to reduce the esophagetic component of the tumor growing in the suprasellar space, to decompress the optic canal, and of course also to confirm the diagnosis of this tumor. What we can do is resume it in this anatomic picture. As you can see, we can decompress also the canalicular part of the optic canal. We can decompress the cavernous sinus and also the calyx. This is just some examples to show that sometimes this meningioma grow in the suprasellar area, so that through the nose we can remove just the part of the tumor growing into the suprasellar space to decompress the chiasm of the optic nerve. And in this video, you see the removal of the medial optocarotid recess. Cavernous sinus has been already decompressed. You have to use, of course, microdoppler probe to check the position of carotid artery. We can decompress the optic canal, but then we can go and remove the suprasellar part of the tumor. We can remove the part of the tumor compressing the chiasm and the optic nerve. Then we can move to another kind of tumor, of factory group meningiomas. You know, we can create quite a large corridor in between the two orbits, the posterior wall of the frontal sinus, and then posteriorly up to the cella. So the corridor can be quite large. As a consequence, we can remove even quite large factory group meningioma with a satisfactory tumor removal rate. But we know that also transcranially there are excellent routes which can allow us to remove quite easily this kind of tumor. So our attitude today is to remove this tumor mainly when the patient is, of course, already anormic, and when there is also an extension of the tumor into the nasal cavity. But if we move then to the tuberculous cell meningiomas, this is, of course, more controversies. This is the amount of cranectomy that we have to realize just in front of the cellular supracellular space to expose this area. But you see the kind of view that we can have after tumor removal is a quite nice view. We can control from one carotid artery to the other one. You can expose also the ophthalmic artery on both sides, wide midline view on the neurovascular structure, and with the absolutely minimal manipulation of the neurovascular structure. The key to remove properly this kind of tumor through the nose is to remove properly the bone over the supracellular area. So the kind of cranectomy we have to realize is absolutely larger than the one we have to perform, for example, when we remove a craniopharyngioma. You see, we have to move properly from the medial OCR to the lateral OCR, and it's very important to remember that we can extend very laterally our bone resection, which can include, if necessary, even the anterior tunnel process. So, when we have to remove tuberculous meningioma from the nose, we have absolutely to remove the supraoptic recess. We have to expose and to drill all this bone over the optic prominence. Otherwise, we will not control properly the carotid artery and also the optic nerve. The key step of the procedure, of course, are the same we are using when we operate transcranially. And this is a video just to show you the main step of the procedure. You see, after a proper large bone and dural opening, we can control the supracranial carotid artery, the ophthalmic artery, the optic nerve entering into the optic canal, and we can quite easily dissect the tumor from the neurovascular structure. Here you see from the pituitary store. Here you see the chiasm with the nerve, and you see that the view we can have is really wide, and you see that this structure has been almost not touched. Concerning the size that we can manage, of course, these are from small to medium size, but sometimes we can, and you see the post-op control, but we have also quite large tuberculous meningioma. You see, this is a case that was operated from above, and you see that the result was not satisfactory. This case was then operated from below with a good tumor removal. This is another case operated from below, and this is the main benefit of the root. You see, you don't manipulate the nerve even in cases when you have a severe neurovascular conflict. Just few words on the result. As you see, the result on visual function are absolutely good. Also, in those cases in which there is a severe neurovascular, severe visual problem, you see the literature is full of paper trying to compare the endonasal with the transcranial root, and especially in Asia, there is a growing interest on this kind of surgery. And another point we have to consider is the optic canal invasion. Of course, when is it completely involved, there is no route which allows you to obtain complete resection, and the same is for vessel encasement. What is important to remember is the sphenoid sinus configuration that can be very useful to remember that when you have a deep cell inside the sphenoid sinus, like that case of this one, the endonasal route is absolutely favorable. But when you have a tumor growing mainly on the planum or on the other side, the transcranial route is much easier. So these are the best case of the endonasal route, small to medium size, deep cellar without vessel encasement. What about planomeningioma? For cases like this one, no way to say that the endonasal, the transcranial route is more favorable. But and also when you have a paramedian extension, like in this case, the transcranial route is absolutely better. But look this case with the severe brain edema, look like this one. So in this case, we prefer to use the endonasal route. I will skip the video, but we were able to remove completely. And also, if you look the MRI control, you see the reduction of brain edema without any damage to normal brain. So at the end, this is our conclusion that the value of the endonasal route for skull-based meningioma is growing from factory group to planoma, and especially for tuberculous meningioma, where the endonasal route seems to have the best benefit. Thank you for your attention, and hope to see you next time in presence. Thank you again.
Dear professors, I'm Dr. Zhao Peng from.
Thank you. Thank you very much, Luigi, for this excellent presentation. I have got one question for you.
Yes, please.
Many a times the bone at the skull base is very hard and hyperostotic, and at times you don't see the usual landmarks like OCRs or optic protuberances. In that case, how do you manage this thing and do the opening and go ahead with the tumor excision?
Yes, you are right. Sometimes we can find some hyperostosis. We rely, of course, on the use of neuronavigation. And what we also try to do is first to find the cella. Once you have reached the cella, from the cella you can move around by thinning the bone all around the cella. And also over the planum, you don't have in the midline dangerous landmark. So that's also another good reference area.
Thank you. Any other question?
Yeah, I mean, it's excellent lecture and excellent demonstration of technique. But as you know, meningiomas have satellite nodules which range from like 2 to 4 centimeters from the margin of the tumor. How that is taken care to prevent recurrence of tumor in transnasal approach?
Yes, but skull-based meningioma, especially tuberculum, in almost of the cases are grade 1. And you have to rely on pre-op MRI to see the dural attachment. And also in the good percentage of the cases, they are strictly adherent to the tuberculum cell and not so far laterally. And the other thing is that today you can enlarge more widely your bone opening over the planum. So you have a better possibility to control also the lateral extension of the tumor. But on the other hand, of course, when the base of the dural attachment is very broad over the planum, it's much better to go from above instead of using the endonasal route.
We have done 58 cases of suprasellar meningioma with transcranial, and at least 3 of them we found aneurysms in the paraclinoid ICA. So we had to clip. Do you have any experience of finding aneurysm during surgery to endonasally? And if you find, how will you tackle it?
As you know, there are cases in the literature of clipping aneurysm through the nose. It never happened to me. What we do in all our cases is to do a pre-op MRI with angio sequences to exclude this evidence. Of course, if you have coexistence of aneurysm and meningioma, we prefer to go from above instead of using an endonasal route.
Okay, one last question by the.
Anybody from the audience wants to make any comment or ask question to Professor Cavallo?
Yeah.
How do you manage if any major vascular injury happens during the extended approach?
If you refer to carotid artery injury for pituitary surgery, there are not big problems because the only thing you can do is compression and then send the patient to interventional neuroradiologist and to call and put a stent depending on several factors. If you consider the intracranial bleeding, for example, from one perforating vessel or some other, the only thing that you can do is to coagulate. And then you have to pay the price for the vascular occlusion. But it's a very rare evenience. I don't think that with the perforating vessel, you can do something different transcranially or endonasally. If it happens, the only thing that you can do with the perforating vessel is to occlude. But the other thing is also to consider that when you have encasement of some perforating vessel, a teeny perforating vessel, maybe another good option is to leave that piece of tumor instead of trying to remove everything.
Any last question from Dr. Ramanamurthy? Yeah.
Have you encountered any problems of ptosis of cerebral structures through the bone defect created in the skull base for long-term follow-up?
Yes, and this is also reported. You can have some herniation, especially if you use soft reconstruction. And this is the reason why we are using now more and more big piece of fat to fill the surgical cavity, the dead space. But in our experience, they never were symptomatic. I mean, the secondary encephalocele or herniation is never symptomatic, was never symptomatic in our experience.
Thank you, Professor Cavallo, for participating and spending your time in for the IFNE meeting. We'll go to the next presentation by Professor.
Thank you so much. Bye-bye.
Bye. We welcome Professor Zhao from Beijing, China. He's a professor at neurosurgery at Department of Beijing Medical College, and he'll be speaking on application of endoport technique for neuroendoscopy in the ventricular tumors. Can you have his video, please?
Dear professors, I'm Dr. Zhao Peng from Beijing Tiantan Hospital, China. As the COVID-19 epidemic explosion, until now we have no chance to go abroad on-site attendance, but I still can enjoy this acceptance and share our experience in neuroendoscopy with this recording video. I hope sooner we'll meet together with each other face by face. Okay.
Topic for my presentation is the application of endoport technique for endoscopy in the ventricular tumors.
You all know intraventricular tumor has a very long history. The location is difficult to reach and adjacent to the important cephalic structures. So the tumor also are usually benign, slow growing, and generally undetectable, at least they are very large. So the traditional surgery is traumatic. It's a very challenge. Ventricular anatomy is important. Also, you must know the CSF circulation after remove the tumor. The endoscope view of the ventricular is also very important. Also, the tumor, the blood supply is very important. It has the branches of the anterior and the posterior choroid artery. Also, we must care about the vein drainage through the ventricular wall of the vein. Now we use a focus set for the intraventricular tumor surgery. Also, we use the freeholder or the special instrument during the surgery. And the endoport, now we use the commercial channel. This is the mature method that we do the operation with a small crane automate. Also, with this is the cut the dura, a small opening, insert the underpart, and then remove the underpart. Or you find the surface of the brain protect very well. The process of underpart, we use this dilation, the balloon dilation to insert the underpart. This is the procedure is very simple. The brain of the tissue pull less, or pull force evenly distributed. We can find this view, this is the video, and the balloon dilation of the cerebral cortex, and then insert the underpart gently, no brain damage. Okay, then insert the underpart into the ventricle. We can find the tumor. Find here video. I insert the underpart into the lateral ventricle to find that this is the tumor, just like a Piro, okay, or Piro dissection the tumor, and then remove the tumor easily, and find here the lateral hall of the ventricle with the irrigation. This is the septal vein. This is the thalamus vein, thalamus striate vein, and these plexus. All the structure protect very well. Remove the underpart here, a very small opening. The postoperative, the pathology is the subependymoma. The patient, the MRI scan and the CT scan showed very good result. Okay, we can find here. Okay, there's no tumor remnant. The second case is a male, 23 years old. It's a right lateral ventricle central cytoma. It's a very large central cytoma. Here, the preoperative CT scan, we can find a very large central tumor in the lateral ventricle with hydrocephalus. Also, the eyesight examination has a very large the eyesight field deficit. Preoperative MRI scan, we can find a very large lobulation tumor here. Okay, just I show you the video. I click the video because of the time, and then after remove some tumor, we find this kind of tumor full of blood supply, and also we can find some CSF comes out under the tumor. Remove this kind of tumor piece by piece, find the normal anatomy. This is normal anatomy. Here, the septum, this is the septum vein, and this the lateral side of the lateral ventricle. And then I swing the underpart to the lower part of the ventricle, and I remove the tumor piece by piece quickly. Okay. Here I just use some curved suction here, curved suction. Also, I use curved calculation bipolar to calculate. This is very useful to treat this kind of tumor, and then remove the tumor here. Do not nervous about this is blood supply, because you can just control the surgical field with yourself, and then remove the tumor here. Just plexus, all the tumor removed very well. Okay, the normal anatomy. This is a post-operative MRI scan. We find the tumor removed very well. The patient recovered and the discharge as usual, and all the preoperative symptoms recovered. And the third case is the male, 49 years old. This case, we can find the preoperative MRI scan is the location, the tumor located near the thalamus. So be careful about the thalamus. Also, the tumor has a marginal lobulation. So this is not a very easy case. Okay, this is our craniotomy, a small craniotomy. I use the navigation, and then here insert the underpart. We find this tumor is not a blood supply well, and then remove this tumor piece by piece here. Okay, okay, here I just also use scissors to cut Okay, remove the tumor piece by piece, and then I just swing the endoscope from endoport from the frontal to the downward. Okay, to find the tumor very well, use endoscope view. Endoscope view can enlarge the surgical site. Okay. Remove the tumor. Okay, here the last part of the tumor, and then I just swing the underpart to the front to find the normal anatomy. Here, the normal anatomy. This is septum. This is the plexus, and the downward no bleeding, and then find here. I irrigation find the mineral intraventricular foramen. This plexus septum vein. And the thalamus right vein here. Then stop bleeding with the surgery flow. I like use the surgery flow. It can just stop bleeding small, and then with the irrigation to irrigate out the surgery flow. Okay, this is our postoperative MR scan. We can find the tumor removed very well, and the postoperative pathology is mesenchymal tumor. Mesenchymal tumor. It's a rare case. Okay, the first case is a female, 35 years old. It's a meningioma. We can find here the perioperative MRI scan. We find that maybe the blood supply is the choroid surgery artery. First, I calculate, insert the endoport, and then calculate the blood supply here, the blood supply here. Okay. Then dissect the tumor from the adjacent ventricle. Adjacent ventricle. Okay, here. Okay. I click the video. Okay. And then remove the tumor totally. You can find here, because the blood supply stop firstly, so you can treat the tumor. It's very free. It's very easy. No blood supply. Okay. Okay. All the operation finished. Postoperative, the patient recovered very well. So the discussion for the neuroendoscopy for endoport technique for the intraventricular tumor is according to the tumor size, the tumor location. Also, the tumor quality is very important. Before operation, you must think about it. Also, the key point for the endoport neuroendoscopy, this is a very just an easy way. It's less retraction. We can take full advantage of neuroendoscopy. And I can put the lens near the lesion, very near, and enlarge the surgical field. And with the hemostatic method, I think I use the surgery flow here. So the application of this technique is according to your choice. It's a must use very familiar with the ventricle anatomy. Also use your exercise. Thank you all.
Hello. Hello.
Thank you.
Yeah. Thank you. Yeah. Thank you for the invitation.
Anybody has any questions to ask? Yeah, Professor Yadav.
Excellent talk, Professor Jha. The question is, what is the size of your endoport, number one? Number two, what are the limitations? Whether you can go from, posteriormost to anteriormost, or the putting in a port is very important, because it is very difficult to move. You can visualize, but very difficult to move your endoport once you are there in the ventricle. You cannot move it from anterior to posterior. So how will you decide when the tumor is large, where you should put in your port?
Yeah. Thank you. Thank you for the question. The first I use the underpot and I use the commercial animal with the balloon dilation and inserted the underpot. The diameter of my underpot is 27 millimeter. So I think it is suitable for you to in the one space, the underscope under the you can use your tools, suction and calculation together. I use the not oral, not the oral the underpot. I use the just circle underpot. I think the other doctors, the other professor use the oral underpot. I think it's no problem. It's your choice. And the second question, I think you mentioned if you use from the frontal to the maybe frontal to the occipital, it's a long way. But as usual, I use the frontal hole, a frontal part, and from the frontal the frontal part of the lateral ventricle, I remove the underpot from the front to the downward, the occipital. It's easily because it's just one, I think one axis, only one axis. Just insert the underpot because my underpot is not very, very long. My underpot is 7 centimeter. I think the other doctor use are long size. If you use the long, very long size, the comes out from the brain surface is very high. It can stop your monument. So I just the underpot from the surface of my operation is very small. I can swing the underpot from the frontal hall to the occipital, no problem. But if I also do some operations for the third ventricle, because insert the underpot to the frontal for the marrow, and then you can see the third ventricle. But sometimes I must calculate the septal vein and enlarge the marrow, and then into the from the underpot into the third ventricle. You can do the third ventricle tumor also. You can do it. Okay, I think no problem. And sometimes I do the operation for the occipital hole. Some maybe meningioma or other. I use this frontal occipital incision because it's very near, just to the occipital hole. It's no problem, just not to frontal size. Sometimes I use the frontal incision. I can make ETV same time. It's very important for the ventricle tumor operation. For the CSS for circulation, you must think about just my PPT, just give you the information, okay? Thank you.
Professor Zhao, can I
Yeah.
ask one question?
Yeah,
What
no problem.
special technique do you use to remove the hard and calcified tumors? Do you have any special way of dissecting those tumor out?
Yes. Yeah, this is a very, thank you for the question. It's in my experience, I have meet the hard tumors in the ventricle. I use what kind of I use the scissors to cut small size and remove piece by piece. But I think I have the you can use the you can use ultrasonic tools and make a small piece. And also we can use other tools to make the hard tumor to small size and remove out. Because the hard tumor in the lateral ventricle or the third ventricle is very difficult to remove totally. Anytime for us make the tumor become small size. It's very important, I think, strategy, very important. I think in brain tumor, every kind of hard tumor is very difficult for you to treat, especially skull-based tumor. If you meet the hard tumor, it's very difficult. You need so many time to remove. The same, I think the same question. Okay.
Thank you.
Yeah, thank you, Professor Zhao, and hope we'll meet in some other meeting next time. We move on to the next
Thank you. Bye-bye.
School of Endoscopy for Gliomas by Professor Puneet Plaha from UK, Oxford University, UK.
Good evening. Thank you very much for the invite at the interim IFNE meeting in Hyderabad. I'm sorry not to be in person. Thank you to Professor Sankla and Professor Panigrahi for inviting me. Over the next sort of 11 minutes, I'll give you an overview of endoscopy for gliomas and where we are headed with it. Now, as you know, the key aim for intrinsic surgery, especially for glioma surgery, is to try and find the oncological and functional balance to achieve maximal resection versus reducing neurological deficit. And as our understanding of the brain increases, we move more towards a functional connectome, understanding the organization on the cortical surface with white fiber tracts connecting different parts of the brain. As surgeons in the operating theater, we look at a number of technologies to try and find this balance to achieve maximal resection for our patients. And among these technologies comes in the endoscope as well, of which you're all very familiar and experienced endoscopic surgeons. The advantage is that we know the endoscope is the better illumination. UV angle scopes allow you to see beyond your line of vision. You can get your operative field close to the site of surgery with the eye of the endoscope with good illumination and obviously see beyond what the direct line of vision shows you. So if you put this all together and use this tool in glioma surgery, I'll talk through our experience of over 200 cases now using a bimanual technique, endoscope assisted, using both 0 and 30-degree endoscope with white light and with 5LA fluorescent guided resections in a cohort of patients having both awake surgery and under general anesthesia. The question then becomes, how do you hold the endoscope? You can use pneumatic holders. I personally use a forehand technique with the assistant holding the endoscope because the dynamic movement of the endoscope gives you a good visualization of the tumor. When you're using the 30-degree scopes, and as you know, if you put the scope at 6 o'clock position, for example, your hands are at 12 to operate, so there's no clash with the assistant. This is just a theater setup with the assistant, the navigation system in the background, the large endoscope screen in front of us. Here we're using the ultrasound as well as an added tool. And we always have the microscope draped in the background ready to use. And I must say, in over 200 cases, we rarely need to use it. Neuronavigation, as said, in all cases, a variety of incisions depending on the location of the tumor. You can make smaller incisions and hide them in scars with eyebrows or in front of the tragus. After making a craniotomy and using image guidance, just to show you the size, it can be slightly bigger as well. We make a corticotomy either through a non-eloquent gyrus or an intrasulcal approach. You use your standard bimanual technique with the malleable suction in one hand, a long bended bipolar on the other. We make a corticotomy tract down to the tumor. We don't use tubular conduits. We line the access corridor with patties after putting Surgicel. And we change the patties, keep them moist throughout the operation. So you have dynamic retraction rather than constant retraction with the tubular system. Long angle Cusa to resect the tumor, this necrotic part of the tumor. Where we are using If this is high-grade glioma, glioblastoma, we change it and alternate it with blue light. So you can look for areas of fluorescence and then change them back to white light as tumor resection proceeds. So you use your standard bimanual techniques for tumor resection. Now, which areas would it be advantageous? I've sort of put them down, and I'll go through each one of them with an example of each given limited time. If you're starting out with using endoscope for intrinsic tumor, I would say using it where there's a cavity or a cystic space is good. Cystic glioblastoma, cystic glioma, or in this case, a recurrent glioblastoma with a recurrence in the posterior temporal region in the pre-resection cavity, and also second recurrence in the parietal region. In this case, to remove the second nodule through a transparietal approach would not be reasonable given the optic radiation on the deficient tractography. And therefore, we did an endoscope-assisted approach. This is just a postoperative scan resecting both of them by putting the endoscope through the resection cavity up into the ventricular system, looking for the second nodule, which I'm showing here with white light. It's difficult to see the second nodule of enhancement. We are looking around, and then we switch on to the blue light. You see in the 11 o'clock position, that area of contrast of, fluorescent enhanced or fluorescence showing the tumor. Again, an advantage of the 5L endoscope, it shows you, then you resect the tumor as you would normally looking at the pink fluorescence. So the second indication would be frontal lobe tumors, and I'll give an example of an eyebrow location tumor. The key consideration here is the location of the frontal sinus. Personally, I don't go through the frontal sinus. This is a grade 3 oligodendroglioma. That's the location of the eyebrow. This is where the frontal sinus is. This is one we did with an eyebrow incision. Resected this tumor. This is the post-operative scan. I'll show you a video of this case where we've done a craniotomy, an eyebrow craniotomy. That's the fish hooks showing the craniotomy. Access the frontal lobe, frontal lobe, standard corticotomy as you do. I would just move it along given time. Diathermy, the arachnoid, incise it with it, and then you use your accuser to define the tumor. And once the tumor is identified, we've switched on the 5LF fluorescence. Surprising for a grade 3 oligodendroglioma, we did see fluorescence here. You normally see it for high-grade tumors, so it was helpful in resecting the tumor, as you see the fluorescence on your screen there. So alternated it with white light and sort of blue light resection to resect this tumor. Vascular tumor extending deep towards the midline arteries. But the endoscope, because you're using a bimanual technique, you're getting control over vascular structure or controlling bleeding is as you would do normally with a microscope-assisted approach. I'm going to move it along. That is just showing the tumor coming off the A1 vessels in the deep part of the tumor. This is just post-operative to show how the scar heals with eyebrow craniotomy. Scenario 3 is looking around corners, and tumors which go around the genu, the corpus callosum, or in the splenium are a good example. I'll show you one, because you can put your endoscope and look underneath the periclosal artery to the contralateral side. Same with the splenium to the other side. I'm going to hold the video here. What you see here, we've done the section of the right frontal component of the tumor. My sucker is underneath the periclosal artery, and with the dissect on the right side, I'm trying to move the genu away from the periclosal artery, where you normally see small perforators. And you then are working underneath the periclosal artery, resecting the tumor to look to the contralateral side and the contralateral ventricular system. And this is, you're resecting it, you get a feeling that you're sort of walking in this sort of cave to the opposite side. This is the contralateral ventricle coming into view. You see the periclosal artery going across. You see both the ventricular systems with the midline structures. So the 30-degree gives you an excellent angulation, as you see here, and a good view. Fourth one, interhemispheric spaces, CP angles, midline interhemispheric spaces, very helpful with the endoscope. This is an example of a genu of corpus callosum tumor in a young patient. You see the faults on the right side. Your endoscope goes along it. As you go down the faults, you start off with a 0-degree scope and then change it to a 30 degrees as you're resecting, because you get a straight view down. Again, fluorescence on, you see the fluorescence of the tumor. You take your biopsies, resect the tumor. As you wait with the CUSA, you now enter the ventricular system because you've taken the genu away. You switch to blue light to look for further fluorescence, continue further resection of the tumor, and that's the cortex preserved at the end. It's actually turned out to be a grade 1 tumor rather than a grade 4. Another example of a tumor in the splenium, posterior interhemispheric approach, thought to be a high-grade glioma, turned out to be ganglioglioma grade 1. Again, posterior interhemispheric approach, we normally have a tumor side down. So the brain falls away with gravity, falls on the right, you see the fluorescence of the tumor, biopsy is being taken, and then tumor resection as you would with a CUSA to resect the tumor. We alternate with white and blue light again. Again, this is what this shows. To check for any residual fluorescence, the angulation in the endoscope gives you a very good visualization of your resection cavity. That's post-resection, alternately checking. Scenario 5, temporal lobe gliomas have put metastasis as well. Temporal lobe, especially on the left, is an area where you get this complex of white fiber tracts within the sagittal stratum. So you have tumors medial and lateral to it. Lateral ones sort of easier, relatively speaking, because the tracts are medial. It's the medial ones which are a challenge. This is a good example here. Tumors high up in the sagittal stratum. We've done an endoscopic approach coming along the floor and then working up below the optic radiation. You see the pre and post-operative visual field defect is unchanged. It is quadrantanopia. We did a pre and post-operative TTI showing you the intact optic radiation before and after surgery. So the endoscope is very helpful working underneath these white fiber tracts. This is just a cartoon depicting that. My last scenario is the thalamus and deeper lesion ventricle system. I'll give an example of a tumor here, the thalamic glioblastoma. This was done under GA with motor evoked potential monitoring. You see the corticospinal tract on DTI lateral and superior to the tumor. What we've done here is done an approach through the, this is the tumor, and we've done an approach through the superior parietal lobule, doing it initially starting off with a 0-degree scope, going down, you see the necrotic tumor within the thalamus. And this is the 5-LA fluorescence. You see the beautiful pink fluorescence coming in. It gives you confidence that you're actually resecting tumor in such an eloquent location rather than any of the normal thalamus or structures. And as you do this, you then enter the ventricular system, you switch over to white light and continue resection. This was again a vascular tumor. You see the pink fluorescence of showing you a residual tumor as you go along. Again, further resection going on. And then this was an area we couldn't see with white light, but picked up on the 5-LA fluorescence to show the residual tumor. We left a small bit of tumor close to the corticospinal tract on the intraoperative motor evoked potential monitoring. Now, if you look at the top left picture, I'll show you a serial slices to show how the postoperative DTI scans look of the tract of the tumor. And DTI is very helpful here in working without causing damage. You see the corticotomy tract with the diffusion tract of the corticospinal tract lateral to it. And this is the end, the intact corticospinal tract and the resection cavity medial to it. So this is a combination of using multiple modality, the endoscope, neuronavigation, DTI, intraoperative motor evoked potential to try and achieve a resection. The outcome in line with published literature, I won't go in detail, but we published quite a number of papers over the years. And the results are in line with what's in the literature. A particular advantage for us in the UK, the short length of stay with these cases, most patients go home within the first post-operative day as well. Last couple of slides. Tubular versus non-tubular. We don't use a tubular system. The rationale being a non-tubular system gives us more dynamic attraction rather than constant pressure around with the tubular system, which causes more stress and damage in the surrounding brain. The other difficulty in the tubular system is once you resect the tumor, the tubular dilators move and you don't get such a satisfactory resection. So my last slide, I think it should be used as a complementary tool to the microscope. If you're starting out, use the microscope, endoscope, use them together. You will, the more you use, as with any endoscopic procedure, more advantages of it you see. You're obviously aware of the learning curve and other issues with endoscopic surgery. And if you're start out with a cystic lesion, cystic hemangioblastoma are a good example, or any cyst where you have space to use the endoscope. Thank you very much.
Thank you, Dr. Plaha. Is he online?
No, sir, he's not online.
Yeah, if he's online, we can discuss if anybody has a question, anything on this. Yeah, Dr. Yadav, any comments, please?
Excellent talk, Dr. Puneet. Any tricks to avoid lens soiling, especially if there's a tight brain?
Neuroendoscopy.
Yeah, when you don't use any tubular retractor, so you use patties. So how you avoid the lens soiling, especially if there is a tight brain?
So Dr.
Yadav,
Dr.
he's
Puneet
not
is
there.
He's not there. Okay.
Yeah, we wanted some comments on it.
I think when you don't use any tubular retractor, the most important point is that your line of axis when you are operating should be 90 degrees to the floor. Otherwise, the brain will fall and then it is very difficult to work.
Yeah, if there are no other comments, yeah, last comment, and we can connect to the next. Is Dr.
Very
Stefan
good
online?
example.
Dr.
I just
Stefan,
want to know about the other persons here, since he is not online, that he's not using endoscope holder. I think his assistance is doing the endoscope, and he's doing the biomanual dissection. Number two is the brain relaxation. We found the brain was quite relaxed, and lesions are not bleeding a lot. So is anybody take that whether they put some lumbar drain or anything, or any size criteria to how much the size we should go for the endoscopic resection, or we should go for other? I think sir, yeah.
I think what you can see from his presentation is that most of the time his endoscope was out of the area of working. Maybe even the brain, the top was seen. So it's very difficult when you don't use any tubular retractor and when the brain is tight, and then you say that with the patties you retract brain and keep working. It is very difficult, but maybe with the experience you can. I mean, you have to keep two instruments at right angle to each other, and then endoscope in between. Dr. Avdesh obviously uses this, so he's not around.
yeah, that means this presentation more on parenchymal tumors. But one of the deep problems with parenchymal tumors deep is like whether one has to use navigation to decide the trajectory, or it has been useful to just use ultrasound also to decide trajectory of the endoscope, and so that only makes it safer. As we're running short of time, we'll go to the next paper by Professor Stefan Ulsberger from Germany, and he will be speaking on Austria. He'll be speaking on complications avoidance in neuroendoscopy.
Yes, sir.
Yeah, is he online?
No, sir.
Neuroendoscopy. Here are my disclaimers. Let's start with a case of a 46-year-old female with subacute hydrocephalus presenting at night. A midbrain oligodendroglioma was already known. This was a picture. You can see there is this calcification in the region of the midbrain and the hydrocephalus. And here is the movie that was actually recorded during the endoscopy. So you can see endoscope is advanced now through the white matter. And well, we cannot see a lot, as you see. And especially we cannot find a ventricle. We're looking around a bit. Yeah, you see there are some white matter structures. But in fact, we cannot find the ventricle. And I will move fast forward because it takes about 1 minute until we see, well, this is striatum now. You see gray and white matter here. And finally, we retract the endoscope, and you can see we're doing now a second pass through the same about bullet-sized tubing that we created. And again, we cannot find the ventricle. So let's go further. Third attempt, we have in the meantime used the Cushing needle and found the ventricle. And now here you can see that the initial trajectory was probably lateral to the ventricle. And now we are in, so we are happy. We see the premolar membrane and we can start to do our ventriculostomy. Well, the ventriculostomy was actually uneventful. However, let's move a bit fast forward. What we can see, well, there are no membranes. That's not the real problem. Everything is flotating. So I think it was finally a success. But now we retract our endoscope. Now we always check the fornix. And what you can see now that we created a lot of fornix contusion because obviously our burr hole was a lot too far anterior. So we have two complications here, 3 passes and a fornix contusion. And of course, that's all because of a wrong burr hole. So that's the post-ETV picture. It doesn't look very good. We even created some contusion in the contralateral thalamus, as you can see, by advancing too deep. And the patient finally needed a shunt and never really reconvalescent from this complication. So the complication rate of ETVs is not 0. It's far from 0. It's 5 to 15% in this meta-analysis. And you can see it's due to bleeding, especially of the basilar rupture and due to neural injury. And I think we need some tips and tricks to improve the safety of this important procedure. So let's talk about endoscope entry points. We are using standard entry points. We're using, for third ventriculostomy, an entry point at the coronal suture and 3.5 centimeters left to the midline. For aqueductal stenting, we know 6 centimeters anterior to the coronal suture and 2 centimeters lateral. What about tumor biopsy in the pineal region? Even further anterior, 7 centimeters anterior to the suture. Colloid cyst, 6 centimeters anterior and 6 centimeters lateral, as you see on the left side, much more medial if we have this colloid cyst with a septal cavity. In septostomy, we use a far lateral trajectory with 2 centimeters anterior to the coronal suture and 6 centimeters lateral to the midline. But we thought, could we do an individual trajectory using our navigation capability? And this is a study that we did in 2014 already. And you see, we checked first our retrospective cases of manually planned ETVs, 59 cases. So they were done without navigation guidance. And we compared them with a fixed burr hole and with navigation planning. So this is what we were always doing. We reviewed our pictures for the exact location of the trajectory, and then we took a ruler and copied that to the patient's head. On the other hand, we would have a fixed burr hole trajectory, 3 centimeters lateral to the midline and at the coronal suture. And here is our proposition, a navigation plan trajectory, where we actually set the target point just in the prepontine cistern behind the dorsum of the cell and anterior to the basilar. We make a waypoint at the foramen of Monro. So we set an entry point at the foramen of Monro. And then we enlarge this trajectory to the tip, to the top of the head, to the 3D model. And you can see that on the left picture. There we reset the entry point. Then we have the ideal trajectory through the center of the foramen Monroe to Pontine cistern. And then we measured the position of the entry point, of course, and the distance of the three trajectories to the foramen of Monroe, so to the fornix and to the thalamus on the lateral side, and in the third ventricle to the thalamus and the hypothalamus. And here are the results, and I think they are quite striking, interesting. On the left side, you see the manually planned in blue, the manually planned burr holes, and the standard burr hole. Standard burr hole is, of course, always on the standard side, so 3 centimeters lateral to the midline at the coronal suture. On the right side, you see the navigation plan, so the ideal trajectory, and it's a bit behind the coronal suture, as you can see, but it's very different from manual plan. And if we measure now our trajectory distance to the fornix, and we see that the navigated trajectory never displaced the fornix, 0%. And the manual technique displaced the fornix in 50% of the cases, whereas even the fixed burr hole technique was better, with only 27% displacing the fornix. And in the third ventricle, the hypothalamus thalamus was displaced in only one case in the navigated technique, 8% in the manual technique, and 24% in the fixed burr hole technique. So you see the navigated technique is strikingly better. So then we designed a navigation protocol using electromagnetic navigation, because first we started with optic navigation, but of course you cannot really see where you perforate the third ventricle. So we thought actually using electromagnetic navigation could be better. You see why. On the left side, you see at that time the technique. There's the emitter in black. There's the patient pinned. Initially, we never pin the patient anymore, even though we use navigation, because with electromagnetic navigation, this is not necessary. And on the right side, you see the stylet inside the ventricular scope. So the stylet now tracks the scope. And you see the stylet can then be advanced even further in the third ventricle, and you can use the blunt stylet tip to puncture the third ventricular. So then we clinically applied this technique in some cases. You see here 16 cases, and very strikingly again, the trajectory never displaced the fornix and never displaced the hypothalamus compared to the fixed burr hole when we did the comparison. So the steps to a third ventriculotomy trajectory plan, to summarize, you set a target point in the pre-pontine cistern, you set an entry point in the center of the foramen of Monroe, and then you reset the entry point at the 3D surface. And then you have to do some small adjustments according to the sulci and vessels. And then finally, you note the burr hole position relative to the coronal suture. And you can see, as in this case, the result is 0.5 centimeter posterior to the coronal suture and 2.5 centimeters lateral to the suture. Here's another one. So if you want to use a trajectory to the posterior third ventricle, you can do the same. You set a target point, you set an entry point in the center of the foramen of Monroe, and then you reset the entry point at the 3D surface. And you see that in this case, the result is very anterior to the coronal suture. So 7.5 centimeters anterior, 3.5 centimeters lateral to the coronal suture. And this is like a biopsy. It's trajectory to this target. Of course, you can create some sophisticated trajectories if you want to use the same burr hole for ETV as well as a biopsy, like in this article that we published. And here is now a very simple case of ETV, which I just wanted to show you, because you see how it works in reality. So now you can see that we are advancing the endoscope and we don't see anything, even though the cortical mantle is very thin. And suddenly we enter the lateral ventricle. You see we're advancing further along the trajectory. and we advance through the center of the foramen of Monroe, and we directly end up at the perfect position of the premolar membrane. Now we advance the stylet, as you can see, through the endoscope, and we perforate the premolar membrane using this blunt tip. So we do this, and we see on the navigation screen, you see on the right side, we see perfectly that we are in front of the basilar and just behind the dorsum cellular. Well, we know this from the endoscope picture. Now let's advance a bit this video. We're now entering with a neuroballoon, and we are now inflating this double balloon, to enlarge this hole that the stylet created. And then we concurrently can inspect the perforation because the wall of this balloon is very translucent. So we check the flotation is very nice. I think there's nothing much to do underneath. And in the end, when we retract our endoscope, we do a second enlargement of the perforation here. So that we create endoscope diameter of enlargement. And then in the end, we retract and we always inspect the fornix. You see, we track the endoscope and we assess the fornix. Look, there's just no touch of the endoscope to the fornix whatsoever. And I think this is what we should aim for. So to conclude, an individualized trajectory planning can optimize the trajectory of the endoscope in relation to important neural structures, especially the fornix, and thereby reduce neurological sequelae. And the continuous endoscope guidance and puncture device guidance, like the stylet, may add to the safety of this, what can be considered standard neurosurgical procedure. So with this, I thank you very much. I would like to show you a picture of the University of Graz, where I'm right now. And of course, I would hope that we both meet in the IFNE Congress in Austria in the future. Thank you very much for your attention.
Yeah. Thank you, Professor Stefan. Is he online?
No, sir, he's not online.
Okay, then. So we'll go to the next presentation. I'd like Dr. Subodh to invite the next presenter.
Our next presentation is Dr. Tadashi Watanabe from Japan. Professor is here. He'll be speaking on endoscopic controlled transcranial surgery, an idea whose time has come. Welcome, Professor.
Hi, hello. Thank you for giving me an opportunity for this presentation. And today I am going to share my experience of endoscopic transcranial procedure for various situations in our practice. I'm going to show where we are now. I think there are three pillars in endoscopic neurosurgery. One is endonasal approach. This is one of the well-developed and mature techniques. As developing techniques, there are endoscopic cylinder approach for intraparenchymal and intraventricular tumors, and the endoscopic keyhole approach for extraaxial tumor. Let me show you endoscopic cylinder approach first. This approach was developed from hematoma removal. Mostly we use 10 millimeter sheaths. Sometimes we use 12 millimeter retractor called Bucite when we need to do a complicated two-hand surgery. This is a case of hemangioblastoma in left saddle, which has a cyst and a nodule. Once the sheath was inserted into the cyst, all we have to do is to dissect the tumor in front of us. By manual dissection in dry field and wet field, The tumor was totally resected. So we left all the small vessels behind the nodule, and the tumor is resected. Trigonal meningioma can be also removed by this method using a high parietal approach. Deep-seated glioma is also the good indication for this approach. Of course, glioblastoma can be treated by this method. In this case, we used the 12mm view site to control the much bleeding during internal decompression. Eventually, bleeding was stopped and almost all the tumor was removed. The second topic is endoscopic keyhole approach for extra-axial tumors, mostly skull-based lesions. This is the example of a supraorbital approach for extra-axial tumors. We make 5-centimeter eyebrow skin incisions and make 2x3 craniotomy. Then the tumor is dissected looking at the monitor in front. The tumor is dissected under an endoscopic view. The tumor is resected and bone flap is replaced and fixed, and the wound was closed. This is a case of follicular meningioma. It is difficult to observe beneath the confluence of the sinus by microscope, but it is easy to observe by endoscope. Small craniotomy was made just beside the tumor, and the tumor attachment at the confluence was clearly observed by 30-degree endoscope. This is a case of multiple falcium meningioma with NF2. After removal of the main lesion, daughter lesions were resected as much as possible by endoscope. There is no breaching structures in the space along the falx between suprasagittal sinus and the callosum. So we can easily access to the tumor. Endoscope is also useful for other lesions other than brain tumor. This elderly patient with dementia taking warfarin developed subdural hematoma during the hospitalization for pneumonia and heart failure. At the onset, she was conscious, but 2 weeks after the onset, she became unconscious, and CT showed a subdural hemorrhage compressing the brain with a midline shift. And the endoscopic minimally invasive surgery was performed by making a keyhole, 2-centimeter keyhole at the center of the hematoma. And the hematoma was removed in endoscopic observation. And this is the case of MVD. All the MVD are performed by mostly endoscopic keyhole approach in supine lateral position in our institute. Recently, we have been working on an underwater endoscopic MVD with good results. What about these cases? What is the best strategy for these tumors? Multilobular fibrous tumor, tumor extending lateral beyond IC. These cases may be the indication for combined endoscopic transcranial and endonasal. This is the layout of a combined approach. There are two neurosurgery team, two endoscope system, two endoscopic holders, two scrub nurses. Looking at the monitors in front of them, we report this method in Genesis in 2018. A safe and cooperative team surgery is available via. There is no microscope above the surgical field. We can talk and make a communication together and cooperate each other. Small opening allows both surgery fields simple. This tumor is extending posterolaterally beyond the cavernous sinus below the optic tract. We combine the endonasal and supraorbital keyhole approach. Keyhole team will remove the anterior extending tumor and the lateral part of the tumor. The lateral border of the tumor is confirmed by keyhole team. Mostly tumor resection was performed from endonasal team. But the corridor to the main mass is relatively narrow and the third nerve is running at the window. Multi-view observation is effective when confirming the running of third nerve. Then the endonasal team removed tumor beneath the optic tract, while keyhole team is supported by dissecting the lateral edge of the tumor or pushing the capsule of the tumor. Since 2019, we introduced 3D exoscope. And routinely, we perform combined exoscopic and endoscopic surgery for brain tumors. Using an exoscope and endoscope, the viewpoint can be switched between outside and inside the surgical field to obtain an appropriate field of view. The surgeon and the endoscopist who hold the camera brace together to proceed the operation. We reported about combined exo and endoscopic two-step keyhole approach for intracranial meningiomas, in which we could show the significant difference in blood loss, surgical time, hospital stay, craniotomy size between classic microsurgery group and the exo-endo keyhole approach group. We could minimize the craniotomy and bony drilling using exoscope and endoscope. This is the case of a trigeminal schwannoma. We chose anterior petrosal approach with exoscope and endoscope. Drilling of the bone and some decompression of the tumor was performed by exoscope. And after some amount of removal of the tumor resection at the posterior fossa was performed by endoscope. Okay, this is my conclusion. We need more simple and easier and comfortable treatment for both patients and surgeons. Endoscope is a key tool to improvement of surgery. Thank you for your attention.
Thank you, Professor Tadashi. Any questions and comments from?
He's online, so we can ask him
questions.
Yeah, excellent talk. You showed subacute subdural hematoma. So
Yes.
in this case, your entry point was at the center of the hematoma. We do a lot of these surgery and our entry point is at the most lateral part and at the most curved portion, so that the whole hematoma cavity can be accessed through this thing. Whereas if you put especially when you use rigid scope. So if you use at the center, then you require larger bone opening. So I think if you keep your burr hole or enlarge the little keyhole craniotomy at the most lateral and anterior or posterior or superior, then it will be better.
Yes, I think there is a two-way to do a surgery for a subdural hematoma. In my opinion, at the center of the hematoma, the thickness of the hematoma is the most thick part. So that means the big space there, and if the hematoma is very big, the distance from the burr hole to the edge of the hematoma is shorter when we put the burr hole at center. And also we put the two monitors at the operating theater, and then surgeon move around the patient, so we can manage the surgery. So I always consider if we put the burr hole at the one side, if there is some catastrophic bleeding from the end of the space, there may be some difficulty to control them because there's a long distance. So in my opinion, I think it is better to make a burr hole center. That is my opinion. Okay.
Some questions. Thank you, Professor. We move on to our next speaker.
Okay. Thank you.
The association. Welcome, Professor. We'll be speaking on minimally invasive endoscopic spine surgery in the hybrid operation room. Over to you, Professor.
Hello. I'm sorry I can't attend. Can you hear me?
Yeah, we can hear you.
Okay. Oh, nice place, Hyderabad. Please start my video. I would like to talk about minimally invasive endoscopic spine surgery in hybrid operation room. I have no financial relationships to disclose. Endoscopic spine surgery represents a tool for the surgeon to provide targeted access to spinal pathology. Essential difficulty and pitfall is anatomical orientation. Once the scope enters the appropriate surgical field, the surgeon can see the clear anatomy through endoscopic visualization. Normally, endoscopy is guided under X-ray image. There's a steep learning curve. So, cadaver dissection is useful. And preoperative simulation is very important. So, this surgery is pinpoint surgery. To prevent these complications and increase effectiveness of endoscopic surgery, we developed the workflow of navigation in hybrid OR, considering the so-called hype cycle, which shows the maturity of emerging technologies. We use artist legal Siemens and blend of navigation with automatic registration system. This is a workflow. The patient is adjacent level disease. So the patient was suffering leg pain after posterior fixation. So we wanted to avoid fixation surgery. So now we can easily find out the entry point and we use the fusion image, planning data, and intraoperative CT. Now we remove the superior articular facet From this window, we remove the herniation. As we planned. Breathing control, complete breathing control. This is a case of posterior foraminotomy. C6, 7 level is difficult to identify with X-ray image. The reference is fixed at the carbon field. Now check the accuracy from the skin and the image fusion. So we can recognize the entry point. Now we feel the bone contact. So bone exposure and check the level. Preoperative marking is very useful. The exposure bone and the anatomical orientation with navigation assistance. So bone removal. This story is made in Japan, and removal and expose the neural membrane. And we could confirm the pulsation of neural membrane, complete decompression. This is a case of L5S1 pathology. Sometimes we use the interlaminar approach. Sometimes we use the transforaminal approach, depending on the pathology. So 5S1 pathology is the deep-seated pathology. So in this case, we use the difference on the bone. So now we check the entry point above the iliac crest. So I exposed the bone and I adjusted the trajectory upward and removal of the bone. So there are bony fragment in front of the foramen. So now we could recognize this bony fragment. Epidural bony fragment. Now we can see the bony fragment So removal this. And the lateral ligament removal to the foramen. So now we can see the epidural part. And the compression of the foramen and confirms the pulsation. Epidural bony fragment was removable. Japan is an aging population country. This is a 77 stroke patient and spondylolisthesis. We planned the tailored decompression. This is a 92 female patient. Herniation. Local anesthesia is difficult for this patient. We perform the tailored decompression. Regardless of the approach angle and the landing point, the exiting nerve root should be protected during the approach. This paper from Charité in Berlin showed a workflow of intraoperative CT. We showed this technique in this paper. Automatic registration in hybrid operation room is a key. Conclusion. Endoscopic spine surgery has a characteristic of a pinpoint surgery. Hybrid operation room enable us to integrate these techniques, such as preoperative simulation, navigation, endoscopic procedures based on anatomy and physiology. Thank you.
Thank you, Professor Shin.
Thank you.
One question. These transforaminal procedures, do you do it under general anesthesia or local anesthesia?
General anesthesia.
Do you do
We prefer general anesthesia under the neurophysiological monitoring.
Okay, under monitoring. Yeah.
Monitoring.
Thank you.
One question from the message. I use the Japanese Nakanishi drill. Nakanishi NSK, made in Japan drill. Chat from the chat question.
Okay. Thank you, Professor.
Thank you.
Very interesting talk. Next, we move on to Professor Speros. And yeah, good day, Professor.
Greetings.
Good morning for you.
Greetings. I'm sorry that I can't be with you.
He's speaking early experience of ventricular lavage. I think he has a video sent on.
That's right. Yes, my talk on video, and then we can discuss live. Yes.
Yeah, sure.
Dear friends and colleagues, unfortunately, I cannot be with you in person, and I do apologize for this, and that is due to work obligations. But it will be my pleasure to share with you my early experience doing neuroendoscopic lavage for IVA. I would like to thank the organizing committee for including me in the program, even though I cannot be in person. And I'm really sorry that I'm missing out the Hyderabad experience. Anyway, let's just move on. A little bit of history. As far as I know, Uli Tomale started the endoscopic lavage in IVH in September 2010. And I think about a year later, he started presenting his work. The first time I heard his presentation, I was rather scared about what I saw. And it sounded rather dangerous. And I was actually overtly critical. And you may remember that if he's in the audience. But as time moved on, I tried it for the first time in 2017. And that first patient still remains shunt-free to this very day. So far I've operated on 6 children, and I think it's a reasonable method, but there are many parameters that need to be streamlined, and that is the purpose of my talk. So what are the reasons for doing lavage? Everybody says it's to reduce the chance of shunting, but as I will develop my talk, I think that should be not our prime priority. The thing is that the first thing you put the endoscope inside the ventricle and you see all this blood, immediately the thought that springs to mind is, oh, all this stuff inside the brain cannot be good for the child and should be removed. So it is almost self-evident that we should do lavage. But like a lot of other things we do, the question remains, is it risk-free? And together with all the noxious substances that we remove in the cytokines and all the blood products that we're removing, are we potentially removing useful substances that the newborn premature baby needs for its development? And that we don't know. So in my opinion, the goal of the operation would not be strictly to reduce shunting rate, but to reduce the harmful effect of the blood in the developing brain. And of course, reduce the secondary fibrotic effects that develop within the ventricular system that we all know and we have to handle later, the lobulated ventricles and 64th ventricle, the damage to the parenchyma and so on, all the stuff that we see every day. So the technique that I use is very much similar to the technique that everybody else is using. I use an endoscope with 2 washing channels. I used to use the stored little Lotta, now I use the Minnow. So it's important, I think, to have separate irrigation and aspiration. And to do that, I use 2 syringes, one to irrigate with Ringer's lactate and another one to aspirate. And I go on and irrigate and aspirate for as long as I can. And when I feel I've completed the procedure, I place a Rickham reservoir at the end through my semicircular flap, as I show here. And I use that Rickham reservoir to do aspiration afterwards. So in the last 5 years, I've done 8 operations in 6 children. I should say that I've done lavage operations in ventriculitis as well, but that's a separate topic. So I've done 8 operations in 6 children. In 2 children, I've performed 2 operations. And the operation age, as you'll see in the next slide, varies between 10 days and 42 days. One of them had a CSF leak and infection and that needed treatment for that. Of the first 5 children that I have followed up, 2 remain shunt-free. The operations were performed at 2017 and 2019. The last patient was lost to follow-up because they went away from my hospital, and I don't know whether she's ended up having a shunt. And we have a follow-up of 58 months, a mean follow-up of 58 months. This is the table with all the material. If you notice in the 4th column here is the operation timing. So the children that didn't have shunt, one of them had at 10 days and the other one had at 26 days. The other ones that had shunt varied 24, 32, and 42 days. I'm not sure what is the relevance of that, to be honest with you, and the number is very small. Here's an example of one of the 2 children that remained shunt-free to this day. It was a girl, born at 32 weeks plus 5 days, grade 3 IVH, September 2019. The first day the first operation was done at day 10. On the right side, you see here, the top row is the MRI scans before the operation, big clots. Big clots on the right side and smaller clots on the left side. Second operation was done 12 days later, and she remains shunt-free to this very day. So my initial impression is that in general, it is easier than I thought to do the lavage with not so many problems. And of course, it's easy if you've done more than 250 endoscopies in children, as I've done. What I'm trying to say is that if you're beginning your career in endoscopy in neonates, perhaps you shouldn't start with that procedure. So far, we haven't had any significant intraoperative problems. We haven't had any significant postoperative problems. But I should say that I'm not doing as extensive lavage as Uli Tomale. He talks about putting 3 liters in and out. I never managed so much volume. So some thoughts on the volume of lavage. Theoretically, you should clear all the blood, but in my hands it proved impossible. Of course, the more I do, the better I wash out. But there's clots everywhere. When you put the endoscope there, it's like diving in muddy water. It's clots everywhere, and sometimes it's not easy. But on the other hand, sucking large quantities of CSF out of the ventricle does not appear to be a problem, which was my main worry when I started these operations. And of course, the question remains: are we sucking out useful molecules together with the bad ones? Are we sucking out stuff that we shouldn't be sucking out? That's always the worry. What about repeating lavage? Traditionally, it is said that you repeat lavage to clear the other side if you did manage first time round. But it may be a thought to repeat lavage if the color of CSF that you aspirate from the reservoir is still dark. But again, the question is if you're doing more than you should be doing. Thoughts on timing, that has to be a significant issue. In theory, it should be the sooner after the diagnosis, the better. In general, neurosurgery, as soon as you get hemorrhage, you want to take the blood out. But in practice, of course, it's not possible to do it from day 4 on a neonate, on a premature neonate. And even if you could, it would be impossible to aspirate the solid clots to the endoscope. So the general idea is that you do it as early as possible. But of course, day 10 and day 42 cannot be as good as far as the end outcome is concerned. So we should really decide what is the optimal timing for this operation. What about acceptability by colleagues and parents? Parents are overall keen. Once you tell them that the blood inside the ventricular system is half full, and then it seems to them very reasonable that you should try and remove the blood. On the other hand, when you tell them that you, for whatever reason, you would like to remove it, but you can't remove it, and you have to stay with the traditional method, aspirating through the reservoir, and it will take 2 months, they look very disheartened, and it sounds to them an awful lot of time to wait for the CSF to clear. So in general, parents accept the idea. And the neonatologists are not too resistant, but our anesthetist is often resistant. There have been many children who would be candidates for washout, but the anesthetist decided that they would not tolerate the procedure, so we didn't do it. And of course, I don't know about you, but I never argue against the wish of the anesthetist, obviously. So to conclude my short presentation, what I learned from those 5-6 cases, first, we need to learn how to do this. And for me, that is how to improve the rate of my clearance of my cleansing of the CSF. So we need to learn how to do it and standardize the procedure. We need to learn when to do it, standardize the timing, and we need a study of developmental outcome. And once we've ironed out these details, then we can do a trial versus standard treatment. I believe Conor Malucci is setting up a trial in England, lavage against standard treatment, but I think this is too early now, at least on an international scene. So meanwhile, I do it when I can, and I learn as I grow. I learn to do more lavage. But in my opinion, the reason to do it should not be the reduction of shunting risk, but the better developmental outcome. Obviously, reducing risk of shunting is important, but I think in the concept of these babies, the lavage would not reduce substantially the shunting risk. So we should aim to provide a better developmental outcome. Thank you very much.
Thanks a lot, Spiros. Brilliant, very, very informative talk and very interesting topic. Just one simple question, as you mentioned that the timing of lavage is something which is very important. Obviously, day 10 and day 42 are not the right times. Apart from that, do you think the distribution of blood clots, in lateral ventricle as opposed to lateral third, fourth, aqueduct, in your analysis, what did you find? The distribution of hemorrhage makes a different outcome?
Well, first, I've done only a few cases, so I cannot really tell you what makes a difference. But my experience is that once you, well, there's, as I said in the video, there's clots everywhere, and you want to remove as much as you can. Many times you see the aqueduct is blocked by organized clot, and you say, "Oh my God, I need to open that." You try. Sometimes you manage, sometimes you don't. It is not. It's not as easy as we think, in the sense that you're doing a lot of good work and you think you're winning, but afterwards, because I always tap from the reservoir, you keep removing bloody CSF for quite a while. So you think, I've done 2 hours operation, or I've done so much lavage, and even though I've done all this lavage, there's still more stuff to come out. So it's. Yes, I'm not sure what's the best thing to do. And Uli Tomale, who I haven't seen him in the video, I haven't seen him in the room. I don't know if he's around. He talks a lot about reducing the risk for shunting. I don't think this procedure will ever reduce the risk for shunting substantially. It will reduce the risk of shunting a little, and obviously that is a little gain. But I think because it will never reduce the risk or obviate or reduce the risk of shunting substantially, I think we should think about it as something that will provide better neurodevelopmental outcome, or at least reduce all these encysted false ventricles and loculations and so on. If we're going to be using this procedure to do something good, I think that's the frame of mind that we should be using it. Yes.
Secondly, Uli and his group, they are very aggressive in terms of washing away the blood and use the volumes as high as 3 liters in small kids.
Absolutely.
Do you have any hesitation in using more?
Well, I put 20 ml syringes in and 20 ml out. To do 3 liters, that means 150 times. Of course, I'm not doing as much. Of course. I never managed to be so aggressive. So I do as much as I can, but I think I'm putting in and out less than a liter. I think maybe I should be doing more. It's not easy though. That's all. Yeah.
Any idea of using intraventricular urokinase?
Never done it, and don't want to do it either. I think it's probably dangerous. Never done it. Never done it.
Well, thank you, Professor. Thank you for the time.
Thank you very much, guys. Thank you. Enjoy.
We move on to our next presentation. Professor Yasuo Zhang is here. Yeah, he'll be speaking on endoscopic intranasal surgical strategy for skull-base chordomas.
Dear Doctor and Professor, hello everyone. I'm Zhang Yasuo from Beijing Tiantan Hospital and Beijing Neurosurgical Institute. The title of my report is Surgical Treatment Skull-Base Chordoma. We know annual incidence of chordoma is very low, but its treatment still faces serious challenge in special skull-base chordoma. Here are problems and challenges we face. Clinical material. From January 2004 to February 2021, 531 cases surgery with skull-base chordoma for Beijing Tiantan Hospital, including primary tumor and recurrent tumor. Tumor location, including this part. Here is tumor location. Clinical symptom here. Surgical approach. In general, we use endoscopy operation, transnasal transoral. As necessary, by combined transnasal transoral endoscopy approach. Sometimes by open craniotomy. Result. Extended tumor resection vary with different surgical specialty. Extended tumor resection different between primary and recurrent chordoma. Common that indeed, common hard sinus have a low total resection rate. Use time tumor resection according to the client's location. Surgery resection rate at different time period. You can see here. Clinical symptom improve after surgery for short-term evolution. Here are some post-operative complications. Follow-up, 8.9% patient follow-up. 5 years overall survival, 65%. We will discuss these 6 aspects. I think our golf surgery for scalp-based carcinoma, maximum tumor resection, prolonged progress-free survival, improve quality of life, pre-operation evolution, including here. I think this fact is also very important. Tumor location, volume, texture, relationship with vital structure, integrity of tumor matter, and so on. Choose endoscopy approach. This tumor is suitable for transnasal surgery. For this case, we use the combined transnasal and transoral approach. So you can see a transnasal and transoral. In this case, just we use in staging and combined approach. Here. Let's talking about the operation difficult and the key technique. I think sufficient reasonable exposure is important guarantee successful operation. Endoscopy transnasal and oral approach can remove tumor at most side of scalp base. You can see here. In this case, compression of brainstem and hypothalamus. Duromet is intact. Tumor can be completely removed with sufficient exposure. You can see here. The tumor invade common sinus and hypocephalus. It's very important exposure. Tumor by protect important structure. The tumor was completely inside and direct reason. I can show you a tumor as big as this, as long as it's full exposure and endoscopy. The tumor can be also completely removed. You can see here. We think that factor affecting resect rate, including 7 aspects, it's very important to explore common remaining site of tumor metabolically. But a lot of anatomic data space. You can see here. Here, many data space. Its life turtle shape is very special recurrent carcinoma. 1 year after Corel's tumor resection, surrounding structure recurrent tumor is complex. You can see here. Scar structure on tumor surface. Remove the by drill, bit by bit. And the biplot of normal plot, electoral calculation. Then expose right internal carotid artery. Then expose left internal carotid artery. Intraoperative navigation at the end time. Past superficial tumor was removed to its positones. The tumor was excised by cutting with CUSA, scissor, electric knife, and cutting forceps. You can see here, adhesion is serious. Separation tumor, brainstem, vascular, nerve, and so on. Intraoperative neurophysiological monitoring to protect her cranial nerves. After resection of tumor, we can see basal artery, bilateral vertebral artery, and posterior cranial nerves. Then, reconstruction of scar base is very important after tumor resection, such as stuffing feed, suture fissure, using biological glue, motive in enforcement, and so on. The tumor invaded jugular foramen. Extended transnasal approach was performed. Exposed to jugular foramen. The tumor here, but here to brainstem and the basal artery, expose and protect important structure. Carefully separate and extract the tumor bit by bit. Systematic treatment. We believe the radiation therapy for chordoma may be useful as method as still and fuse study. Prognostic effect. There are many factors influence prognostic. Degree tumor resection is crucial for long-term outcome. The result electron microscopy was used to predict prognosis. The dural penetration are associated with different prognosis. Some biomarker can predict prognosis. There are our paper on clinical and basic research of scar-based chordoma. Conclusion: early diagnosis and treatment of broad wall for chordoma. Endoscopic techniques should be used in almost the case. For surgery, first time is best time. Surgical experience is very important. Systematic may improve outcome of treatment. Thanks for hard work, every team member. Thank you very much.
Thank you, Professor. Difficult topic. Any questions and comments from the audience? Anything?
Professor Goto, you want to comment anything on the paper?
Okay. Thank you. Nice presentation. I'm Takeo Goto from Osaka, Japan. I have one question to the chordoma surgery. In some cases, recurrence after the radiation. When we resect the tumor around the carotid artery, there is some risk to damage the carotid artery. How to prevent this complication?
Audio is not coming.
Professor Zhang? No audio.
We can't hear you.
From his side, there is.
Mr. No audio. Oh.
Professor, we can't hear you. I think something from audio from your side. I think there is. Yeah. Okay, I think we'll discuss some other time. Thank you, Professor. We missed your audio. We move on.
I can answer the question. I can answer the okay. We are the group. I'm the Professor Zhang is my director. Okay, just the very good question. I can answer the audience. Okay, he asked if the patient with the radiotherapy and the recurrent tumor around the carotid artery, we just use some. Maybe we use navigation, we use the ultrasonic and find the ICA and then remove the tumor. If the tumor adherence is very serious, sometimes we remain it. We remain the chordoma because if everyone knows chordoma, the chordoma recurrence is very high. If you totally remove under your endoscope, also the patient can have the recurrent. So sometimes protection is the first choice under the safe way. So our option, we may choose remain the remnant tumor around the ICA. But if you can remove, you can do it. So every time we face this serious case is very maybe is dangerous, is a challenge for all of us.
Thank you.
Okay.
Thank you very much. We move on to next Professor Ulrich. He'll be speaking on endoscopic assisted craniosynostosis surgery. That was recorded.
Dear ladies and gentlemen, first of all, I would like to apologize not being able to come to Hyderabad, which I really regret, and I hope I can follow up on this at a later time point. For now, I'm very pleased to give you our experience about endoscopic assisted craniosynostosis surgery. First of all, the growth patterns are changed in craniosynostosis due to early closure of one or more of cranial suture, and this can either affect the cranial growth, so the cranial vault, or it can also impair the facial growth by deformity mainly. So this needs to be taken into considerations in further follow-up. The most important and most frequent single suture synostosis are the sagittal suture synostosis, the metopic suture synostosis, the coronal, and the lambdoid. Of course, there are more multiple suture synostosis also in syndromic cases, which are even more rare, but we would not go too much in detail about the numbers. What is the indication of surgery? Mainly aesthetic. However, we know even in single suture synostosis, a tiny proportion will develop increased values of ICP during late development of young adulthood, which is much more often the case in complex or severe deformities in syndrome cases. The diagnosis is mainly done by the typical head shape. So, but phenotype of each craniosynostosis. So clinical judgment is very important and experience is needed. Further, we have the ultrasound in order to see if the suture is closed, yes or no. We avoid X-rays as well as CT scans here in Germany a lot in order to avoid radiation exposures, and MRI are done in all complex cases and lambdoid suture synostosis in order to see if there is indirect changes referring to an increase of intracranial pressure, CSF flow disturbances, or carrier malformations specifically. We decide in relation to the growth pattern of the cranial vault, destabilization and remodeling techniques. So in the early time period, the growth dynamics of the cranial vault allows us to do semi-passive surgical techniques, which need to be transferred into active techniques after the age of 7 months, for example. We can do conservative treatment by just doing observations if the phenotype is not exaggerated too much, and in surgical techniques, mainly the type of surgery depends on the age, basically. So endoscopic assisted surgery is done typically in Berlin between 3 and 4 months of age, and there we do an extended suturectomy, a plastic decompression, and then apply a helmet for 9 to 12 months as a subsequent orthesis therapy that looks like this and will be manufactured individually per case. This technique is, of course, among all the others, which are more active techniques, specifically at 9 to 12 months, the frontal-orbital remodeling, or at higher ages, total cranial vault remodeling, if this is necessary. If we look at our patterns of surgery in 2015 here on the left side and 2019 on the right side, you can clearly see that the part of endoscopic surgery has clearly increased. So up to almost half of the cases in sensitive sutures are now treated endoscopically, and even in metopics as well as a coronal suture synostosis, we do much more often endoscopic surgeries, but it depends on the age and also on the consultation of the parents. Here's a typical scapulocephalic change in a sagittal suture synostosis, elongation of the sagittal convexity, biparietal narrowing, frontal and occipital bossing, and sellar deformation of the vertex can be seen. You can also palpate the sagittal ridge accordingly. There are different kind of patterns of growth abnormalities, which needs to be taken into considerations when you do the diagnosis. Can be pronounced more anterior, posteriorly, centrally, or as a complete pattern. The endoscopic technique was firstly described by David Jimenez, as well as Constance Baron from the United States, and they did it firstly also with sagittal suture synostosis, applied a suturectomy via 2 incisions and did some lateral decompression, then applied helmet therapy and reported from early on, this paper is from 1998, a positive results about this technique. You can see one example pre and post-op. We did start in maybe 2000 with using this technique and slightly increased our numbers. The sagittal suture synostosis will be done by 2 incision and with biparietal decompression. However, we always leave the intact sutures intact during surgery, which is very important in my opinion. We do 1 incision in frontal suture synostosis and coronal suture synostosis, and do mostly a suturectomy, but also sometimes an additional cutting of the bone for decompression. The helmet therapy is part of the therapy. That means the suturectomy is only to destabilize the condition, and then the helmet will use and shape the dynamic growth of the head in order to make it normal as possible. And we know that this works by treating posterior plagiocephaly, which are not related to craniosynostosis. The indication for surgery will be taken between 3 and 4 months. I already told this, 2 incisions, one behind the anterior fontanelle, the other one in front of the posterior fontanelle, and then we work from 2 sides, and endoscopically the periosteal as well as the epidural space is prepared before taking the bone out. You can see this sphinx positioning in the surgery room, our techniques and instruments which we are using. Here you can see the 2 incisions, the preparation of the bone. Then the epidural space was already shown. You can see that the bone was already taken out. You can see the dura and the bone edges, and here the dura with the sagittal sinus, which need to be taken care of. And then after the bone is taken out, we do lateral incisions that the bone at the end will be destabilized and you can easily move it. Again, the lambdoid sutures on both sides and the coronal sutures on both sides will be taken intact because they are still needed for the further growth. This is the amount of bone which we take out in addition to further cuttings and the rhonchoid parts, of course. How to judge the results? This is not as easy in all craniosynostosis cases because how to judge something which is beautiful or not beautiful, what fits the expectations of either the surgeon or the parents. So more objective measures are indices of growth patterns as well as 3D photography, which then can be transferred into volumetric models and then see where the head is growing and where not. So this has been done in a recent work of ours, sagittal suture synostosis before and after surgery. You can see the scapulocephalic shape, and this was normalized after endoscopic surgery and helmet therapy. And in a video, you can see the comparison between the growth patterns which are happening in the biparietal region. These are the positive changes of the skull. And in the next video, you can see the negative changes. So the bossing in the frontal area, as well as the bossing in the occipital area was diminished. So this is how the shape of the head got more and more normal. This is a trigonocephalic case with a metopic suture synostosis, very typical. You can see the ridge of the frontal suture here. You can see the hypotelorism and the loss of coverage over the eyebrows in the supraorbital region. The incision is done anterior to the fontanelle, and then you can work all the way down to the skull base as well as posteriorly to the fontanelle. The incision is maybe 2 to 3 centimeters in length. And then can be applied. We take the bone accordingly, and then we have to use long rhonchos in order to go all the way down to the skull base. And here it's very important to reach the nasofacial suture because only if this is really the bone is decompressed until this level, the skull is able to widen in the facial region. So this is one very important aspect. We also use, and nowadays more, the drills in order to get rid, because this is a little bit more fast and less blood loss can be applied. After that, we also do some lateral incision in order to do some relief of the skull base in these areas. And at the end of surgery, we apply some thrombotic agents and then taken, and the skin will be glued with a skin glued accordion. You can see our morphometric changes, trigonocephalic shape, pre-surgery and after surgery and after helmet therapy, a nice normalization. And you can see our growth pattern against here is the positive growth in the both sides in the supraorbital regions as well in the posterior region, and we have less growth in the biparietal region because these are the growth patterns of the trigonocephalus. So we actually want to have reduction in these areas, which we can also prove by these morphometric evaluations. This was also quantified by different indices, and here you can see control groups, you can see endoscopic group, and you can see the open group of sagittal suture synostosis here in both diagrams, and you can see that the postoperative changes are very similar between the open and the endoscopic surgery, as well in the second index. And this is also the case very similar to the metopics, where we reach normal growth patterns in the endoscopic as well as in the conventional group. However, we need to say that the endoscopic is much less invasive compared to the open technique, especially in the frontal suture synostosis. This is also the case for the coronals, and for the coronal have one side closed, leading to anterior plagiocephaly with a reduced supraorbital bone coverage of the eye, of the orbit, as well as a facial scoliosis and this anterior plagiocephaly. This is the technique with the incision lateralized. We work the suturectomy not above any sinus, which makes it much more easy, and then take the bone away all the way down to the temporal region. This is the postoperative, and this is the preoperative. And you can nicely see how this part of the bone has grown accordingly. Sometimes we do also some additional decompressive incision down to the mid-pupillary line to relieve some of the skull-base bone areas. Another case, preoperative here on the right side, postoperative, nice normalization, as well as nice growth pattern, almost to normal over time. Another photo documentation where you can see basically the same. This was one case of lambdoid suture synostosis, which comes with a scoliosis at posterior plagiocephaly, as well as different heights of the ear localization, as well as clear asymmetry of the skull base, leading to unilateral carrier malformation. And this is our intraoperative view. You can see here the incision is done in the middle of the suture, and then you can work up to the posterior fontanelle and down to the skull base. Here it's important to be lower because we want to be as close as possible to the transverse sinus region in order to make that safe as possible. We use also loops in order to get better illumination, and use it in combination with the endoscope and the illuminated retractor. The time of surgery is much less compared to coronal and lambdoid suture synostosis surgery. If you do it open, it's less different in sagittal suture synostosis. Our complication rates are rather low. It's a very routine surgery. If we look at the literature, we can basically see on a wide basis that surgical time is reduced, hospital stay is reduced, as well as transfusion is reduced. And in the Europe paper, which came out this year in pediatric anesthesiology, you can see that the amount of epilepsy after frontal switches of frontal remodeling techniques are cut down by down to 20%. So it's 0.06%, very, very rare in endoscopic diseases. The technique was widened by different groups around the world, also to complex suture synostosis. That means bicoronal, for example, some syndromic. And here we do also this since maybe 3 years, basically on the with the goal in order to normalize the further growth patterns, not necessarily to get the perfect result after 12 months, but to have a better precondition if another open surgery is necessary to do. It's also important to emphasize that many different disciplines are necessary in order to take care of those sometimes complex patients, especially if you go into the syndromic diagnosis. There, a multidisciplinary approach is very important. So you need a big center, a big pediatric center to take care of those patients. Thank you very much. I I hope I could cover the topic as far as possible, and I'm open to answer questions if there are any.
Thank you, Professor Ulrich. One
Uli, are you there? Oh, yes.
Yes, I'm there. Hello.
Brief question. Up to what age do you do this operation?
We do this between 3 and 4 months because we need.
No sound.
Can you hear me?
Yeah, we can hear.
Okay. You need to do it between 3 and 4 months. This is our rule. So this needs to be done as early as possible because you need the growth dynamics, which happens afterwards, and the bone should not be too thick. Sometimes we have done exceptional cases done at the age up to 6 months, but this is really rare. And then we look also for the body weight not being higher than 8 kilograms.
Thank you. Thank you, Professor. We move on to
You're
our presentation for the day. Professor Joachim Ortel. He is speaking on MIS TLIF with EasyGo. Professor Ortel.
Hello, everybody. It's a pleasure for me to be part of this meeting and to present endoscopic options in TLIF fusion. My name is Dr. Oertel. I'm professor of neurosurgery in Saarland University, director and chairman of the Saarland University Hospital, Department of Neurosurgery in Hamburg, Germany, and I'm president of the IFNE Society. These are my disclosures. I have to disclose that I received support by Ulrich Company for MIS fusion, and I hold patents with Karl Stoll's company in Germany. This is where I'm from. So we are in the center of Europe, southwest Germany, about 1 hour drive from Frankfurt, Luxembourg, and Strasbourg. The department is a very digital department in MIS techniques and endoscopic procedures. We have about 3,500 cases per year and about 30 colleagues in 4 theaters. In the department, the first microdiscectomy was described and the development of the CASPA system was performed. So there's a long tradition in MIS spine procedures. So minimally invasive transfemoral lumbar interdiffusion, so TLIF, has undergone significant evolution. The benefits of spondylolisthesis reduction via minimally invasive TLIF remains poorly understood. And MIS TLIF offers advantages of reduced soft tissue trauma, decreased postoperative pain, and reducing the rate of complications. Just here, one recent systematic review of the 2014 in MIS versus open TLIF, PLIF, surgical time and blood loss and in hospital time was reduced. Clinical results are very, very similar and complications were similar. There was a total of 26 studies included. Unfortunately, there was a low to very low quality of randomization, etc. However, as a result, there was similar surgical time, less blood loss, shorter in hospital stay, similar clinical results, similar complication rate, and significant cost saving in the US. Our own data is that we analyzed close to 2,500 lumbar osteocentesis in 2012 to 2020. 830 of these were MIS procedures, and it was a retrospective analysis. Just in a case example, it's a male patient, 79 years old, short history. Patient had severe back pain for about 4 weeks, combined with radiation, both knees. There was discomfort in the soles of both feet, and the patient could only walk a few steps because of this severe pain. MRI showed severe stenosis and mild spondylolisthesis L4-5. So this is the example of the CAT scan. So you see the severe stenosis and the massive degeneration of the facet joints. So how do we proceed this? Then we do MIS percutaneous instrumentation with 2 C-arms. So we do via separate skin incision, introduce the K-wires in the transpedicular position. And then we use straight T-lift cages filled with bone graft. And this is an example of the procedure. You see here under endoscopic view, then we did do the interlaminar fenestration and decompression. We use a lot the diamond burr to do the interlaminar fenestration. So for your orientation, the upper part of the screen is medial, the lower part of the screen is lateral. And then the yellow ligament is exposed. Yellow ligament is resected. And now the decompression of the severe stenosis is performed. We start with the ipsilateral decompression. So we go from the midline, lateral, ipsilateral. Then we open up the disc space after removal of the set joint. We evacuate the disc space step by step. Retract the thecal sac. Use the instruments to clean the end plate and to take out as much this material as possible.
Sir, it's a PPT, so he's just talking on the slide. It is not stuck, sir. It's running. It's a slide.
And this is the intraoperative X-ray. During the cage insertion, it's important to bring the cage in and the decompression before bringing in the screws. Otherwise, it's not possible with the endoscope. And now, after decompression and cage insertion, we use the K-wires for the posterior instrumentation of the percutaneous technique. And this is the X-ray result. So when we analyze the results, actually 42% of our cases had earlier lumbar spine surgery. The mean age was 66 years. The mean BM body mass index is 27. Close to 70% had single-level surgery, 23% had two-level surgery, and 8% had three-level or more level surgery. Mean surgical time was 200 minutes, almost 200 minutes. Mean blood loss was 700 cc. And the shear endoscopic decompression we performed in 12 cases. All procedures were performed with the EasyGo system. Case insertion was possible in all cases. All cases were performed with a large size trocar and Medtronic capstone Ulrich Detzo cages and a percutaneous internal fixator. The mean follow-up is now 12 months. We had no nerve root, etc., no revisions. All procedures were possible through a short single median skin incision. It was performed bilateral decompression via unilateral endoscopic tube-based approach and a TLIF single cage insertion. And then within subsequently ipsilateral percutaneous pedicle screw placement and contralateral pedicle screw placement. So to compare our MIS with this open techniques, it's almost the same case distribution. So single level close to 70%, two level about 1/4, more than two level about 7 or 8%. Mean surgical time in the MIS was a little bit faster than in the open techniques. Mean blood loss was significantly less. Clinical results after 3 months were similar, and complication rate was also similar with a trend to the MIS endoscopic procedure. What are the pitfalls? Tendency to stay too small, too far medially by the use of one skin incision. The compromise of the adjacent facet joint with a too far medially placed pedicle screws. Prolonged learning curve is needed in contrast to open approach, and you have no direct control of the input position. So you really have to know what you do. It's more complex, this procedure. However, if you have this in mind, it's a safe and effective stabilization technique with minimal complication rate. Percutaneous surgery using dorsal stabilization allows the positioning of the pedicle screws in an equivalent safe manner compared with the open technique. And there's a high demand by the patient and surgeons, no additional risk and superior aesthetic results. So this is the surgical technique of choice for us in selected cases. Thank you for your attention.
Thank you for Professor Ottel for sending the video in the last minute. And it means it was only spine presentation for today's evening. I'll request if anybody wants to have any questions or want to comment on the presentation. Yeah. If there are no other questions, we'll conclude the session for today. We have a dinner. I request all of you to join for the dinner. It's just across the hall. And tomorrow morning we start at 7:45, and buses will be there, shuttle buses from 7:15 onwards from this place to the conference venue that is around 1 kilometer from here. So you have shuttle buses every 15 minutes going on. We'll go from 7:15 onwards. So you can have the breakfast and come for the conference at 7:45. Huh? Yeah, that's the cold breakfast. Yeah, breakfast will be available from 6:45 onwards. And yeah, breakfast is in this hotel only. Tomorrow onwards, the lunch and dinner will be in the conference venue, and breakfast for 2 days will be in this hotel. In the respected hotel, both Tara and Sitara. So I request all of you to join for dinner. But if you want to have a stroll till 9 o'clock, you have the lighted Ramoji. You can have a stroll around and come in at 9 o'clock for dinner also. It's your choice whether you go directly for dinner or go for a walk and come for dinner. Thank you for attending. Can you have a group photo? I request all of you to come here, so at least we'll have a group photo for today's attendance. I request everybody to come on to the dais here.